This is the California State Senate.
This is the California State Senate.
Morning.
We have one more report coming out of this.
Good morning, all you enthusiastic seniors, and not so. Good morning. I'm Senator Carol Lute. I do apologize for keeping you all waiting this morning, but traffic was really challenging today. It's, as always, coming out of LA. So I'm State Senator Carol Lute, and I chair the Senate Committee on Aging and Long-Term Care. And I'm really pleased to see the group here today. And this is going to be a series, this is our first informational hearing today. And today we're going to discuss the California system for delivering services to older adults. We will examine the current challenges and opportunities to create an ideal system. What do you think? That best needs the needs of our consumers. We had planned to give you an infographic that was going to be developed to indicate to you the 20 different state departments and 112 long-term services or programs that currently attempt to meet the needs of California's older adults and adults with disabilities. Just to show you what we have to deal with, the confusion and complexities of what we have to deal with. But we didn't get that here in time, and I hope that when you signed in, you gave us at least an email address or something that we can begin to communicate with you directly and perhaps show you things and communicate with you in that way. So, in addition to having a disjointed delivery system, budget, limited resources have diminished in the state's service delivery system in more recent years. And today we have a California aging and long-term care system that is not providing statewide access to a range of services, especially in rural areas, not responding to the cultural and ethnic diversity of our state, not developed a skilled, highly developed workforce to meet our growing demand, not collecting data in a uniform and thereby unable to measure outcomes and identify best practices, not using a universal assessment tool for consumers and their caregivers, or not supporting caregivers, many of whom are aging themselves. So past efforts to reform the aging and long-term care system have failed for a variety of reasons. Limited resources, term limits, I'm out in 2 years, lack of political will. But, you know, actually we can no longer ignore the needs of this growing segment of our state's population. And we also need to view their needs in the context of the 21st century. In the needs of, we know that research has advanced. We know that medicine, technology, preventive care, as well as increased longevity are all part of the countervailing elements. So this select committee's mission is to explore these challenges and articulate a vision for an effective and efficient aging and long-term care services and support delivery system. In the coming months, we will develop a comprehensive strategy for how to achieve that vision, both legislatively, if it needs, and administratively. So today we start with establishing a new structural vision, answering such questions as, what values underlie an ideal system? What is an ideal system? what are the essential elements? What are the major barriers or challenges to achieving an ideal system? And how do we achieve the ideal? So we have a packed agenda ahead, so let's begin. We have today with us some of California's most leading and renowned experts and scholars in the field of aging, and you will find their impressive bios among the hearing's handouts. Just two housekeeping elements here. We're going to try to adhere to a time schedule, and who from my staff is going to have those minutes held up? Okay, we'll have somebody from my staff to talk about, hold up a card that speakers will have, warning you, you'll have 3 minutes left to indicate you've got 1 minute to go. And also after, I'd like to, after the four presenters present, I'd like to hold off on the public comment following the last presenter of the afternoon. And so to begin with, let's begin with Kate Wilbur. Who are the consumers and what are their needs? Kate, thank you for joining us.
Thank you, Senator Liu. And let me say it's an honor to be here and be on this distinguished panel and be talking about a topic near and dear to my heart in an area that I've worked at for a long time. Can you all hear me? Am I too loud? That happens sometimes too. And I have to say, this is like Old Home Week. It's really great to see so many friends and familiar faces. So I'm going to be talking about who are the consumers and what are their needs, but I'm also going to be talking kind of with a global overview. So next slide. I just want to say that in addition to my own work, I've drawn upon several sources, and these are good for you to know. The Camry study, which is a collaboration among some of the UCs, and they've analyzed macro data from Medicare, Medicaid, and in-home supportive services. The Home Project, and Steve Wallace is the head of that project, and there's really good information coming out of that. That project interviewed in depth people who are getting long-term services and supports, and I think it provides wonderful insights into what their experiences are. And then the SCAN Foundation, and if you go to their website, they've got briefs and fact sheets and lots of really good information. So you'll see as I go through that my slides come from there. So the service delivery system we're talking about is really broad, and in one sense it has to connect with medical services, and that's acute, hospital, primary specialty care, post-acute. That's not what I'm going to talk about, but I think it's important to keep that in mind. I'll be talking about more the long-term services and supports, home and community-based services, and nursing facilities, which are part of that, and the critical role played by informal caregivers. Next slide. So if we think about the population, it's a very diverse population, and it includes older adults, younger adults with disabilities. It includes children. I won't be talking about children as part of this, but I think it is important to recognize the breadth of the populations, the breadth of the settings in people's homes, in community settings, and in 24-hour care facilities. And as you all know, it's really important in the context of long-term services and supports to have individualized, person-centered care. Next slide, please. So many of you have seen this, but I like to use this slide. So first of all, what is this? This shows that currently we don't have person-centered care. We have program-centered care because the programs are in silos with their own individual eligibility requirements. People have to access each one individually. It's very hard to transition among these services, and you'll see here one side is medical, one side is more social. There's a chasm between those two sides, and it's very often, does the physician know that there's a nutrition program that might be out there? If someone's in the nutrition program, do they know maybe there's an adult daycare? How do people travel among these services to get what they need? And as we move, and we are starting to, with work on universal assessment and coordination, we're moving towards more person-centered. And I hope in the not too distant future I don't ever have to show this slide again. So the next slide. So how did they transition? Well, this is a study we did a while ago called the spider web, and this is actually, we looked at referral patterns and communication patterns, and these are broken into clusters. So without the clusters, it looks even more like a spider web. And this is a difficult thing to navigate for the consumers, for their caregivers. How do they know, again, who to call, how to get there? Do they take information with them? Probably not, because things have to be reassessed. So next slide, I like visuals. And I just want to point out that over a decade ago, the Institute of Medicine said that this system is a nightmare to navigate, and that it's much better for consumers and cost effective if we improve the ability of people to navigate by improving the service delivery system. So this is a very important thing to be working on. Next slide. So looking at what is long-term services and supports, it's paid or unpaid care over an extended period of time, at least probably more than 90 days, and it's assistance with activities of daily living, the very personal care of bathing, toileting, dressing, mobility, as well as assistance in the more environmental context that people need to function in our adult society, so money management, house cleaning, shopping, all those kinds of things. And it's also linking to and managing the chronic conditions that are at the core of why people need these services. And so if we look at just some basic demographics, 1 out of 5 older adults has a diagnosis of diabetes. If we look at where the healthcare dollars go, and this is total healthcare, 95% of healthcare costs for people over the age of 65 go to chronic conditions. We also need to ensure, as part of these services, that people are safe in the homes. There's been a lot of great work done on fall prevention and activities to help people self-manage, as well as for some people who need protective supervision in the home to ensure that they don't wander or they don't in any way endanger themselves. So very broad kinds of services that we're talking about here. And who are the consumers? There are people of all ages who have either physical or cognitive disability, and they're really us. If we look at the data, 70% of people over the age of 65 will need long-term services and supports at some point. And over half will spend some time, either a short stay for rehab or long stay in a nursing facility. The average length of time is 3 years. So we all know that we go to the doctor and we have to take care of our health, but I think for a lot of people, this need is kind of invisible. They don't recognize that this is something that most of us will need at some point, and some of us already need or have used these services. So what are the characteristics? About 60% of people who use long-term services and supports are over the age of 65, and we know that these chronic conditions increase with age. The fastest growing segment of our population is the over 85, and they're also the group most likely to need long-term services and supports. But I do want to make this important point that age is not a proxy for need, so that we can't make assumptions that somebody who's 85 or 95, or this is a picture of me with Jim Beeren, who's over 95, and is really quite an amazing person. He goes to the gym 5 times a week, and he's an inspiration. And he's kind of the father of gerontology. An important point, which I'm going to reiterate, is the diversity of users. And this isn't how I would have broken out these data, but this is how they come. So racial and ethnic characteristics, a little over 1/3 of long-term services and supports users in California are white, about 1/4 are Latino, 1 in 5 are Asian Pacific Islander, 15% are African American. So again, the diversity of our state is reflected in the diversity of the service use. And what services do people in long-term services and supports use? Now, this comes from the in-home supportive service data. One of the issues is, how do you measure this? Well, it's measured in that program of like almost 500,000. So of the people that are getting help. What are they getting? Well, 2.6 are getting 2.6 help with 2.6 out of the 5 ADLs on average. Almost all people in this program need help with all the instrumental activities of daily living, shopping, cleaning, that kind of thing. And then this, I think, is kind of a remarkable statistic. Almost a third live alone. And these data were collected in 2008, but 8% had to stay in a nursing facility, and 37% had some cognitive limitation. I want to talk really briefly, and I think other presenters will as well, as the importance of the informal family caregiver system. That's where most of the care is provided. In California, more than 6 million people are providing informal care for a family member, or in some cases friends. 1.5 million are assisting someone with Alzheimer's disease or a related disorder. And 1 out of 6 households has someone who's an informal caregiver. And then the amount of care that's being provided, the average is 21 hours a week, and it's almost a full-time job, 36 hours a week when they live together. 29% provide that very personal care, assistance with daily living. The majority of informal caregivers work outside the home, and their contribution to California was estimated to be $47 billion, almost $500 billion nationwide. So that's a huge contribution in any way that you slice it, and really important to support caregivers. So the Home Project, which gives us insights into the daily lives, the expectations, and the needs of people who use long-term services and supports. We talk about caregivers, that's really important, but they say that a number of consumers have fragile networks, or they don't have support, informal support at all. So they observe that the extent of social isolation is profound and has implications for the mental health and well-being. We know that isolation makes people more vulnerable to abuse and neglect. And we also know that a good delivery system is important, but we need a person-centered philosophy that drives it, that really nurtures the human spirit and really attends to quality of life. And I want to just give you a little bit of the voices of the consumers, and I think Dr. Wallace is going to talk a little bit more about this study, but to look at the individuality and the quality of life. So this gentleman, Roy, was diagnosed with neurological and psychiatric conditions, and he says, "One of my greatest fears is being institutionalized, not being able to live independently and to be able to come and go, to be free, to have that freedom. I think those are very important aspects of life. Those are the things that give me a lot of joy." Okay, and then Vicki, who has a lot of formal support, she says, "I want to be independent at this stage in my life. It feels so good that you can still take care of yourself at 89, because not everyone can do that," and I think by that she means she's not in a facility. And then finally, the caregiver who gets the quality of life dimension. This is not probably part of her care, but she says, she has the balcony, you know, the flowers make her feel fresh and happy. So that's why I help her water her plants. And those are all the things that, I mean, with medical care, we don't think about plants and things, but in long-term services and supports, these are the really critical things. So we need a strong system where people will talk more about this. We have an increasing aging population, and over the last few decades, we've seen shrinking funding at the state and the federal level. So I just want to leave you with this. So it's important to have the adequate array of programs embedded in a strong system to get services to the right place, the right time, provide those pathways to navigate. But service delivery systems in and of themselves don't care. They can't provide that essential foundation to support a person-centered culture that attends to everybody's unique needs and preferences. So we need to infuse the service delivery system with that philosophy. Thank you.
Thank you very much. Thank you. Next we have Sandy Fitzpatrick, who's the Executive Director of the Commission on Aging, and Steve Wallace, who heads up the Department of Community Health Sciences at UCLA School of Public Health. who will help us understand the state's current aging and long-term care system. That
Thank you, Madam
mesh.
Chair. Next slide.
Thank you.
Today I'm going to speak of the evolution of long-term services and supports, describe the challenges, and offer a list of influences, and doing it with the members of the commission looking over my shoulder. Next slide. I believe this is the chart, Senator, that you were saying earlier, but I didn't know how to interrupt you to get my slide up there. Commissioned by the Office of Senate Research. I guess it was a confluence of variables and resources that resulted in a complex patchwork of long-term services and supports. You're going to see a bunch of diagrams today that all describe the system in different ways. And while this table is impressive at first glance, I don't want you to be fooled. Numbers of services do not make a system, and I think they support what Kate had said. We're still in silos when you look at those one-size-fits-all boxes. Next slide. Long-term services and supports developed in California since 1970 on, from a robust service initiation in the 70s to expansion in the 80s to heartbreaking reductions in the past decade. The long-term care system evolved and then literally fell apart. The one truism that guides California is that people needing long-term services and supports prefer to receive these in their home and in their community. California was once seen as an innovator and a leader. The 70s brought the establishment of the Commission, the Department of Aging, and the 33 area agencies on aging. In 1972, the first independent living center in the nation started in Berkeley. ONLOC and the Family Caregiver Alliance formed in response to needs. The Long-Term Care Ombudsman was initiated along with, here comes alphabet soup, and that's probably a piece of our system problem. PACE, ADHC, MSSP, and IHSS. In the 80s, state dollars, oops, that was going to be a surprise slide, but that's okay. Leave it up there. In the 80s, state dollars were used to build the area agency network of home and community-based services, linkages, Alzheimer's daycare, HICAP, and respite. A state Alzheimer's task force was formed, and several programs were transitioned to CDA, department, in an early effort to consolidate. In the 90s, the State Independent Living Council was created and the Olmstead decision handed down. And look at the, oh, you can, go ahead now. Now the surprise slide. Look at all of those reports. Futuristic planning started in the 90s, 20 years ago. Some reports highlighted the changes anticipated with the baby boomers, and others called for restructure. Next slide. Back one slide. Really? There's not one in the middle? Okay. That's interesting. Go ahead one slide. Okay, back, never mind, I lost a slide somewhere along the way. Let's hold on this one for a minute. There were a number of calls to action, state reports, good thinking, lots of policy work that went into documents such as The Challenge is Clear, the Time is Now, written in 1995 and just as relevant today as it was then. SB 910, Vasconcellos, called for a strategic plan for an aging California signed by the governor in 2003. And under Assemblymember Berg's leadership, the Assembly Committee of Aging and Long-Term Care, a three-part document, Building an Aging Agenda. Unfortunately, I see people nodding, thank you for the history lesson. Unfortunately, many of these well-intentioned recommendations have not been fully implemented, and sadly, during the same time period, 7 prominent pieces of legislation that proposed to consolidate and integrate care all failed in the legislature. And then the economic downturn, and in the past decade, services were eliminated and the lives of consumers disrupted or worse. These are headlines from my colleague, and I won't read them because now you've had a chance to look at them, chronicling the dissemination of the aging network. Next slide, please. This slide, courtesy of the SCAN Foundation, talks about the government system that exists in our state. Currently, services and supports, I think this is the true long-term care vision as opposed to that patchwork earlier, are spread over 6 departments. Again, another way of looking at your spider web, but from a state government perspective and the difficulties there. Next slide. The sky is falling, or so it seemed, as faltering economies at the state and federal level diminish the funding that has historically supported our programs. Next slide. Nowhere is that more graphically portrayed than in this document prepared by the Congress of California Seniors. There is a correction here. Adult day health care is X'd out, and it does still exist as a licensure category and was moved to a different waiver. This chart tells me that policymakers are ignoring the intersection of demographics, disability, and longevity. Next slide. The bewildered consumer. There are several challenges facing California. Some of these are well developed in the briefing paper, so I'm going to zip through those. Fragmentation. While California provides important services, our evolution occurred and remains in a silo, except for maybe managed care. But to my takeaway, it is not an easy system to navigate. Assessments have highlighted the importance and the lack thereof state leadership in creating vision and setting goals for what should be included in a system and making those a priority in the budget and political process. Capacity. Not all programs are available statewide, nor are they funded at a level that could adequately serve each county. For example, Tony, hi, we're using you for a minute, there's no assurance that should your grandmother need a service today, they can access them. This is especially challenging in rural California where the lack of home and community-based infrastructure does not exist. A few more challenges. Most of you have seen this next, please, thank you. Most of you have seen this chart in the baby boomers in the dark in the middle. California lacks comprehensive data to evaluate our system. There are at least 7 plans that potentially impact the same population at the state level, and we are still waiting for a uniform assessment for consumers and caregivers. Longevity, I think you've heard this before, the older adult population is projected to grow exponentially, along with the number of working age persons with disabilities, and the shrinking subsequent generation will impact a family caregiver crisis. If you look at your number today and think about what that's going to be in the future. Next slide. California faces a severe shortage of professional and paraprofessionals, particularly in the health field. And just a second, because I see in the room a number of local level providers, the real work is done at the local level. But years of chronic underfunding, increased demand, and increasing poverty rates of older adults has created a system in stress. Some providers are successfully changing their business model. Others have to close. A significant example of service loss is with CBAS. 52 centers have closed, 22 here in LA County. Another example was the 49% budget cut to the long-term care ombudsman program. In LA County alone, that was a loss of $1.1 million, closure of regional offices, and a 50% reduction in caseload. Some other influences that impact, the next slide please. No Wrong Door is the federal effort to look at aging and disability resource centers. Just a point, in 2004 we had 2, today we have 7. You figure out how long it's going to be to get statewide impact. A significant change at the Administration for Community Living, bringing together functions for aging and disability, setting the potential for similar action in the states. While we celebrated the Elder Justice Act 3 years ago, we're still waiting for an appropriation to follow. California, influenced by federal policy and fiscal concerns, launched into managed care, but Amber will be doing that soon. From my observation, there's much more collaboration and networking among consumers at the local level, within state government, and through efforts such as the SCAN Foundation-funded California Collaborative. Next slide. Today is the first hearing of the Senate Select Committee on Aging and Long-Term Care. We hope, Senator Lieu, that your committee's efforts can open wide the policy window for substantive improvements in California's LTSS system. Thank you.
Thank you. I know we're going pretty fast, but thank you, Dr. Walker.
Great, thank you. Thank you all for being here. So both Kate and Sandy provided a really good overview of the system as it looks at from the state level, and I'm going to provide a little more information from the home study that provides some of the consumer perspectives on the long-term care system. So next slide. So I want to thank Catherine Keatsman, who's the project director, and Jackie Torres, who actually put together the majority of this presentation and are really key forces in making this all go. I also want to point out, Kate noted with a couple quotes from the home study that what people define as independence, which is really the core of the study, is really very different. And I don't have any quotes, she provided some good ones. But when we talk about maintaining independence at home, we're really talking about keeping people living at home as long as possible as they desired to be. And we've had some really interesting conversations with older adults who most of us would probably not say are independent, but who feel very independent. Kate mentioned one of those individuals. The home study is based on interviews with 54 different sets of individuals who are Medicare and Medicaid eligible, who receive long-term services at home, and who we've been following across 5 counties, some of them for as many as 4 years. So now, how many of you have family members who need help at home? Okay, so I would say we've got a lot of good expertise in this room, independent of the work that we do. What distinguishes our study is we've actually followed these 54 people. We've interviewed them up to 8 times around the state, and I think we have a really good range of experiences. So I can talk about my mother, Kate can talk about her father and mother. So we all have personal experiences, and I think it's looking across these cases that makes this particularly important. As I think probably every speaker here will do, we want to thank SCAN Foundation for supporting this work. Next. All right. So we looked at the programs as the various programs around the state. Here's where we put the care recipient, the person-centered care in the center. And what this is going to do is show you the range of services that some of our respondents have depended on to be able to maintain independence at their home. There's a number of services that I'm sure were on those slides as like little letters, but I want to point out because they do come up over and over again that we don't typically think about when we're talking about long-term care systems. The first of one is housing, and when you say housing, you say, well, duh, of course you have to have a house over your roof over your head to be able to live independently. But a lot of when we're talking about long-term care services, we're thinking about in-home services or meal services or care coordination services. That all assumes a person has a place to live, and I'll talk about that with one of the cases in a little while. And then the other one is income support. So California has reduced its SSI, SSP levels over the years. And once again, to be able to afford basic necessities that allows you to live independently, you have to have enough income to purchase those necessities, in addition to all of the services that you receive. And then last, because a lot of us have pets at home, we actually encountered a number of persons who receive long-term care who are very dependent on their pets for social support and companionship. And once again, we often don't think about that. And the lengths that some of our respondents have had to go to keep their pets healthy has been a major concern and preoccupation of theirs as well. Okay, so 2 issues I want to touch on briefly, and then I want to give you the insights from a couple case examples. First of all, what really struck us was that persons' needs are dynamic. We may go in as social workers and case managers and do an assessment, but that assessment is at a point in time. And what we have found is that people have ups and downs. Some people get better, a lot of people get worse, and that this provides a challenge for being able to manage independently at home. So Gladys, who's 80 years old, had some health problems, and she said, before I was able to bathe without help, so she was relatively independent, and she's helping me with bringing in the groceries, so that's her IHSS worker. Every little thing that I was able to do around the home, she helps me with now. So this is a woman who had experienced a decline and whose in-home supportive service worker was important in helping her remain independent. And then there's Mitch, who is a good example of the good days, bad days. And we all have good days and bad days, but when you've got disabilities and mental health problems, good days and bad days are even more important. He says, I'm like a lot of people. On good days, I do too much, wear myself out. On bad days, I don't do anything. And so you really have to learn to pace yourself. It's really hard for me. I need a day to recover. So support networks can be adequate on the good days and inadequate on the bad days. And so the unstable and ever-changing needs of recipients of in-home supportive services and long-term services and supports is really important. And I think that really emphasizes the importance of the consumer direction that we have in IHSS, because on good days, they can redirect some of their care to one area, and on bad days, they can redirect it to another. And they're the ones that know when are the good days and bad days. The second sort of overarching trend is that the system itself is dynamic. We've complained, I know I've been doing long-term care research for 30 years, we complain that nothing has changed, but actually things are constantly changing, not always for the better. So as the system changes around individuals whose needs are changing, it's really important for them to have information and to be able to respond to those changes appropriately. But being able to understand the system around them, the changing system around them, and respond to that can be a challenge because both physical and mental health can get in the way. So Wilma, who's quoted here, is an 85-year-old grandmother who considers herself to be a lifetime learner. She went back to complete her education after her husband died and spends a lot of time listening to books on tape about art and travel. She has heart disease, arthritis, and chronic pain. And so what happens when the system around her changes? She says, well, Medicare is always sending me paperwork on what I want, on what group I want to go to, and what drugstore I want to deal with. I can call HICAP, I think it is, and talk to somebody there and get some information, but I haven't been feeling good enough to do that. So because of her down days that she was having when we were talking with her, she just didn't have the energy to even pick up the phone and call HICAP. So she gets these papers, they say, what do you want to do? And she puts it on a table and says, I'll get to it when I can feel better. And that provides a major challenge for being able to help her coordinate her services. So let me very briefly give you 2 case studies. I just saw the little flag going in the back of the room there. So the first one is Margaret. This is a case study of a woman who actually has a really dense, well-functioning support system. She has dynamic needs, and she juggles a lot of those needs to provide the services that she gets. She's legally blind, has diabetes, heart disease, depression, and depression actually comes across in, I would say, the majority of the cases that we have. So mental health needs were one area where we were really surprised as we went out and started talking to people. That wasn't part of the reason they were getting in-home supportive services. That wasn't part of their in-home package typically, but that was an area that really was important. So let me just say here that her granddaughter is both her IHSS worker and provides informal support. She is very lucky because when she has needs that aren't part of one of the standard services, her granddaughter can help fill in. And so she's able to go to church on a weekly basis. She gets to the doctor. The Blind Center for people with vision problems, she uses that and has been very good. So this is a best case example. But what she says is, I do what I can, but there's a lot of things that I can't. I can't think of any program that it wouldn't hurt if I lost it. So she's a best case example, and she's saying, I can't imagine doing without any one of the things that I have now. And then the next example, which I'll fly through, so there is also written testimony that'll be on a website, I believe, that goes into a lot more detail. Fran is a Chinese-American woman who's 84 years old, whose probably biggest problem is fibromyalgia, so she's in constant pain. She's also socially isolated. Her son lives across the country. And as you can see here, she has a lot of needs. So she gets IHSS and a little informal support from her son. But she has problems with transportation. She has missed appointments because transportation doesn't show up. She's not sure how to get transportation. She pays fees for her doctor when she can't get transportation to get to the doctor. She needs dental and mental health care that she can't get. She has also been having trouble keeping an in-home supportive services worker. So she's been socially isolated, and on top of it, her house was foreclosed on. There's a 7-year wait list for Section 8 housing, and she is the other extreme of somebody who has basically almost no support and is not clear how she's going to manage. So overall, maintaining independence in the face of uncertainty means managing a complex and fragile web of formal and informal supports. Many of the respondents we have are experiencing increasing disability and unpredictable physical and mental health needs, and the mental health needs are one of those big areas that are frequently unresolved and unmanaged. Almost all of them have unmet needs and could use more in-home hours, especially on those bad days. And if they're lucky, they have informal help that can fill in the gaps. And when they can't fill in the gaps, most older adults just make do with what they have. So this is a group that doesn't tend to complain a lot. So there are policy recommendations, but actually there's where we should go in the future. So just very briefly, person-centered care is important. Ensuring consumers are well informed is a challenge. And developing continuity of care provisions so that older adults can continue the care that works for them is also important. And if you want, the URL healthpolicy.ucla.edu/home study is our website, We have about a dozen case studies that are 4 to 6 pages that really go into depth, including the ones and others that I gave you, as well as all the reports that were shown in the little purple banners. So thank you.
Thank you. So, Ms. Cutler, you are a staff attorney for the National Senior Citizens Law Center, and you're going to help us explore emerging policies impacting our current system. Thank you for joining us.
Thank you. I'm really honored to be here and part of this panel. I feel somewhat out of my league, but I'm going to continue on. You can go to, skip that slide? Yeah, this slide. I'm going to focus on giving an overview of 2 emerging systems, the Medi-Cal expansion into the rural counties and the implementation of the Coordinated Care Initiative. And I'm going to somehow do that very quickly despite the complexity of both of those transitions. So I'm going to start with the expansion of the Medi-Cal program into managed care in the rural counties. In 2011, we saw the state of California move individuals who had Medi-Cal into managed care plans. That was a mandatory transition. Individuals had to choose a Medi-Cal managed care plan. And in that transition, there were about 240,000 individuals who were enrolled into Medi-Cal managed care plans. But when California decided to move forward with that transition, they decided we are going to leave the rural counties out of that transition because the rural counties present unique challenges that we're just not ready to deal with yet. And so now the state has decided we're ready to deal with it somewhat. So we're talking about 28 rural counties. And the expansion is going to look very similar in terms of who's impacted as the SPD transition did back in 2011. So we're going to see all of the individuals who have Medi-Cal only be transitioned into Medi-Cal managed care plans. Dual eligibles, those with both Medicare and Medi-Cal, most of them will not be impacted. They have the choice to voluntarily enroll into a Medi-Cal managed care plan, but they don't have to. The only exception to that are dual eligibles who live in the county organized health systems, the COS counties. Those are counties that have only one health plan, and those counties' dual eligibles have to enroll into Medi-Cal managed care plans. There are also other exclusions. For example, if you're a Medi-Cal beneficiary who has a share of cost, or if you're a Medi-Cal beneficiary living in a nursing facility, you're not going to have to join a Medi-Cal managed care plan. But for the most part, if you're a Medi-Cal beneficiary in those rural counties, you are now going to have to join a Medi-Cal managed care plan. Next slide. Because of the unique challenges in the rural counties, the state of California, the managed care plans were very reluctant to enter into contracts with the state of California to start delivering the Medi-Cal benefit. There aren't a lot of providers. The beneficiaries are spread out. There aren't all of those services that we see in the other counties. So in response to that, the state of California actually developed a new type of model of delivering managed care benefits, where we see 2-plan model or geographic managed care or the county organized health system. In the rural counties, the state came up with what is called the regional model. And the regional model actually includes 2-plan counties. There are 18 of those. But instead of having a local initiative plan and a commercial plan, instead it's just 2 commercial plans. So 18 counties have 2 commercial plans that will be responsible for delivering the Medi-Cal benefit. Then we have Imperial County and San Benito County, both also regional models, but very different as well. Imperial has 2 commercial plans, but 2 different commercial plans than the other 18 counties. And then San Benito is different all on its own. It only has 1 commercial plan. And again, I think that that's because the plans were really reluctant to enter into contracts about delivering managed care. And finally, there are 8 county organized health system plans, and that's the community, the partnership health plan, and it's responsible for delivering Medi-Cal benefits in 8 of the counties. Next slide. So the timeline for the implementation of Medi-Cal managed care into the rural counties differs depending on the type of county. So if it's a county organized health system county, that transition actually happened back in September of 2013. So all of the Medi-Cal beneficiaries and dual eligibles were mandatorily enrolled into Medi-Cal managed care plans in those 8 counties back in September of 2013. The remaining counties, that transition is supposed to happen sometime in 2014. The timeline has been pushed multiple times already here in 2014. I do know that we have commented on the notices that are going to this population and that they're in the final stages of the edits of those notices, which means that I'm pretty sure that that transition probably will be happening in September or October, most likely. But we still don't have a definitive timeline of when the remaining 20 counties are going to move forward with this transition. Next slide, please. So in total, there's about 75,000 duals and SPDs, those with Medi-Cal only, going to be transitioned into Medi-Cal managed care plans. Oh my gosh, I'm gonna have to speak really quickly. Into managed care plans in the rural counties. I think like the SPD transition, the same challenges we saw there we're going to see in the rural expansion. For example, continuity of care. In the SPD transition in 2011, only 11% of beneficiaries that were evaluated knew that they had even continuity of care protections. That ends up being a very big protection if you know that it exists, but that ends up leading to a lot of disruptions if you don't. Network adequacy is a big deal in the rural counties since there's not a lot of providers. Also, the 2 commercial plans operating in the counties. One of those plans is very new to California, has no relationships with the state of California or any of the providers in California. So that will be a very difficult challenge. And then the last bullet is the one I'll focus on for the rural expansion. In the rural counties, the coordination of services remains a very big problem because a lot of benefits continue to be carved out of managed care, most notably long-term services and supports. So that will continue to be the case in the rural counties, which means that the managed care plans have no ability to coordinate that care across the continuum. All right, next slide. All right, the Coordinated Care Initiative. I'm gonna speed talks because I wanna make sure we get some points out here, because I only have 1 minute. The Coordinated Care Initiative started on April 1st. It's in 8 counties. You can go to the next slide. We should all know about that here in Los Angeles. Passive enrollment started here on July 1st. I'm not going to get into the enrollment timeline because it is so complicated that it would take me a good hour just to explain that. But there are the counties. Next slide. The Coordinated Care Initiative includes 3 major changes. First of all of those carved out populations, those with a share of cost, those living in nursing facilities who are Medi-Cal beneficiaries who didn't have to join a plan, they're gonna have to join a plan now. The second major change is that long-term services and supports are going to become a managed care benefit. So those managed care plans are going to be responsible for the long-term services and supports. And the final and most controversial, I think, and talked about change is the development of the CalMedi-Connect program. That's the combination of Medicare and Medi-Cal benefits being delivered by one health plan. And that's going to impact our dual eligibles only, those with both Medicare and Medi-Cal. Next slide. Next slide. So there's about 1.2 million individuals impacted by the Coordinated Care Initiative across those 8 counties. That's a huge number of individuals being impacted. I think the complexity of the transition itself is going to cause a lot of issues. I think we've seen that already, plus the complexity of the population. Dr. Wilbur talked about just how complex the population that we're serving is and that are impacted by these transitions. And that has become very clear. There are enrollment issues that can also ultimately lead to disruption in care. But there's also a ton of promise with the Coordinated Care Initiative. This is the first time that health plans are actually talking and thinking about long-term services and supports. They're reaching out, or community organizations and providers are reaching out to them to talk about how to best serve this population. For example, the Independent Living Centers or the Alzheimer's Association. There are contracts being put in place. There are long-term services and supports that the plans are going to provide. There's the assessment process. There's the hope for a universal assessment. All of this is a lot of hope that can come with the Coordinated Care Initiative that I think all of the speakers have talked about would be wonderful as a best practice in delivering, or a best system delivery model. But with that, I think we all have to be very vigilant. These are both very complicated transitions, and that if we lose sight of the process in transitioning, if we don't have adequate notices, if we don't have adequate continuity of care protections, that those lacking in the actual transition process undermine the goals of care coordination and access to care, and ultimately the rebalancing from institutional living to home and community-based services. So I think we all have to remain vigilant in helping carry out these transitions that are going to impact such a complicated and complex population. Thank you.
Thank you.
Hard to coordinate the tongue sometimes.
That's very good. Okay, so we're only about 15 minutes behind. And just to kind of summarize the takeaways here. We heard that the current system fails to organize around the consumer needs and has been plagued by fragmentation and years of budget cuts. Consumers and caregivers fail to receive necessary services because they don't know they are available or how to access them. New programs such as the Coordinated Care Initiative attempt to address some of the system's shortcomings through better coordination and access to services, and the CCI has placed a significant emphasis on budget savings while attempting to pilot programs in 8 of the state's largest counties with varying degrees of success. We need to step back and consider what it will take to meet the delivered coordinated care so that seniors and people with disabilities can access the right services at the right time in the right place in accordance with their needs and preferences. It's kind of a summary of this morning's panel. So I have 4 questions. If you were to choose one shortcoming of the current aging and long-term care system to tackle today, what would it be? Who wants to try that? Okay, Kate?
Okay, well, I have a stake in this, but I've always said we're looking at money follows a person, and it doesn't, and information doesn't follow the person either. So I think the efforts to develop uniform assessment to make it person-centered and to make it able to be transferred across programs will be a good step forward to address some of the fragmentation.
Okay. Anyone else want to try that?
I guess my bureaucratic hat is on. It's about state leadership and political will and mobilizing an advocacy base to move us forward. That gets us to the system.
Thank you. Okay. Mr. Wallace?
So speaking for the consumer voice, I guess I would like to see more consumers at the table so that it follows a little bit up on Sandy's perspective, so that it's obvious what the experience is on the ground versus just the numbers that we tend to look at.
Okay. All right. I've got questions for CCI, so hang on, Amber. So what is or are the biggest barriers to progress? And how would you suggest the legislature tackle these barriers? You won't offend me.
Could you repeat the question, please? Biggest barriers to progress. I think that what Sandy said, I think that there is the political will across the board, and the bureaucratic obstacles become somewhat insurmountable, it feels like at times. I think that if we could get past that. I think also Dr. Wilbur talked about how things are program-centered right now instead of person-centered, and moving out of those silos of programs, I think creates, would knock down some of those barriers.
Okay.
And I think we can't minimize standard operating procedures and the way things have been done for a long time, and the difficulty of transforming a system that serves lots of people and is very large and impacts across all the counties. So we're moving fast. We looked at some other states and how long it took them, and I think we are on a fast path. If we could stay on that, that would be good.
Okay, great. Okay, so I'm going to go back to CCI. Amber, if you were to suggest one fix to CCI, what would it be?
Oh, gosh. We put out a fix list of 26 items, so that's a challenge. If there were one fix, honestly, I think it would be the continuity of care protection. I think as people are transitioning into that program, I think all of the promise of the Coordinated Care Initiative, the policies that are in place and what can happen are all there, if we can get there. But the transition of people into that and keeping the plans accountable is a different question. But to get there, we have to make sure that people keep services, if they keep seeing their providers. I think Dr. Wallace's team in the most latest UCLA paper talks about what continuity of care means to people. And right now what we're seeing is that there's no blanket continuity of care. There's no protection that, although on writing it sounds great that you can continue seeing your provider for 6 months, but you have to know you have that right. The health plans have to agree to that, and then the provider, most importantly, has to say, okay, I'm going to enter into that contract. And that's where it falls apart. And if we really want this transition to work, we really need to maintain those relationships.
Okay, so finally, what role should the legislature play in overseeing a CCI?
A very large role, I think. I think the state, I think the program is just so complicated, the transition so complex, the stakes so high, that the legislature should be often and frequently asking the state what's going on, what problems there are, and engaging the stakeholder community. All of you who are in the room are seeing consumers come in and be confounded by what's happening. They don't understand it. And making sure we're in touch with the stakeholders who are serving the beneficiaries so that you hear that directly from the on-the-ground leaders and advocates.
Thank you very much. Let's give our panel another round of applause. Thank you. So our next panel, we have 5 distinguished speakers who will help us envision an ideal aging and long-term care system. And in the interest of time, I will let them introduce themselves. We'll make some time for them to come up to the table here. It's Fernando Torres-Gil, who is from Director of Center of Policy Research and Aging and Public Policy at UCLA. Steve Wallace is going to stay. Laura Trio, who's a General Manager for Los Angeles Department of Aging. Karen Lincoln, who is a Associate Professor at USC School of Social Work. And Cheryl Phillips. Dr. Phillips is Senior Vice President of Leading Age. So thank you very, very much for joining us.
Well, then you only have 3. Thank you.
So, welcome, Dr. Torres-Gil. Welcome.
Start?
Yep, please.
Oh, thank you.
Thank you.
And thank you very much, Senator Liu, for continuing to provide legislative leadership on what I think some of us would characterize as an emerging crisis and opportunity. So thank you, and to Patty Berg, who led this charge some years back. Thank you for organizing us kittens. It's not easy to get us all scheduled. And to all of you that are here, I understand we just have 5 minutes, 5 to 10 minutes at the most. Oh, that many? My gosh, I have a 3-hour lecture that I do for my students. A number of you are in the room, but I will shorten it dramatically. We've been asked to describe what I assume we consider the perfect or ideal system. First, let me thank the earlier presenters. They did an excellent job describing the challenge in moving forward. And I love Dr. Wallace's reference to what is a complex and fragile system. Complicated, you saw all those charts and the silos. Fragile because budget cutbacks and the lack of political will mean a great deal of uncertainty about will it be there when we might need a particular service. Sometimes I get a little discouraged because I've been involved in this, like many of you, since the 80s, 90s, and through today. We've made major steps forward. I remember the 1990s, John Vasconcellos, the strategic plan. We had great hopes, yet we've taken 2 or 3 steps backwards because of budget cuts, I think primarily, and the continued lack of political will at both the federal and state level. Notwithstanding the wonderful leadership, Senator Liu, by you and others, we do need to have a larger catalyst from other members at the state and federal level. But notwithstanding that, I do remain relatively optimistic. So if I was to describe an ideal system, I would list 7 or 8 points, and then I'll describe what I'm doing to prepare for my eventual needs. And those points have been mentioned in various ways, but I'll just list them quickly. A single point of entry so that we can figure out how to navigate this, especially if one is isolated, has a cognitive impairment, does not have family or advocates. How can that one individual navigate? Secondly, the availability of what I would call sophisticated and persistent advocates and or consultants and or friends and or family. I think given the nature of the system, we all need somebody to be our lead to figure this out and to enable us to move forward. Thirdly, a system that ultimately has a relatively easy transition across that continuum of available services, and that, of course, is about integration and reorganization. Fourth, an available workforce, a workforce of both professional and informal caregivers that certainly increases families, but to me, an ideal system would allow us to have a choice between family members or professionals. In reality, we may or may not want our family members to do the informal or intimate care. So knowing that there's a workforce of individuals that are available and hopefully affordable. Fifth, which is often not included, but it was in one of the charts, housing and transportation. Housing and transportation. People, those like John Pinus and others can go on for a long time about the importance of housing and available housing and accessible housing, etc. Transportation to avoid isolation. The next one, I think on my number 6, is culturally compatible services that would address the needs of an increasingly diverse population based on age and language and ethnicity and immigration status and sexual preferences. The next one would be protections. Protections from fraud and abuse and exploitation, not often mentioned in a long-term care continuum, but we're certainly well aware of the many stories that occur with individuals who are taken advantage of. So to me, those would be the ideal variables in a system. Now, my particular case, just to personalize it, I think increasingly we all recognize that not only are older individuals in need of such a system, but younger persons with different types of disabilities or limitations, and those like myself that have been aging with a disability will need to have access to this idealized system as I have described. In my case, I'm fortunate to have a wonderful spouse. She's here, but I won't identify her because she's actually here working. And have a great family, immediate and extended. We both are fortunate to have the financial resources. We still work for governmental entities that are still providing defined benefits, which will soon be go the way of the dinosaur, except for those of us baby boomers that are lucky to have that. And so we have choices. We have choices. And in my case, because of my disability, I know I need to plan ahead, so we're already setting the infrastructure in place. A wonderful condo in downtown Los Angeles. I have my motorized scooter there so I can go around to the outdoor performances, to the bars and restaurants, and to enjoy myself. But we're also looking at a potential continuing care retirement community so that our family members don't have to do the heavy lifting, as I tell the younger people in our family. Look, all we want is for you just to come visit us and take us for a drive every once in a while. We'll pay somebody to do the ADLs, for example, and the IADLs. And in terms of cultural capacity, there's a wonderful facility, CCR, called the Palms here in Boyle Heights, the old Hollenbeck home. So me and my Latino buddies are talking about winding up there and pulling our money together to hire mariachis on a Friday evening and to utilize their transport services to take us to some local Mexican bars in different parts of town and or to musical performances. And hopefully our resources and our savings will last long enough for us to enjoy this. So I just shared this as an example that if I added one other thing to this idealized system, it's education and resocialization for younger populations to begin to plan ahead for their inevitable long-term needs, whether or not we have the system. I believe that if we can educate and resocialize those who are in middle age, not yet 50 years of age and over, perhaps we can build a political constituency that can support Senator Liu to get other members of the state legislature, as importantly members in the Congress, to once again reenact such programs as the CLASS Act, to move forward with the work of the Administration for Community Living, to maybe finally in our lifetime have a universal long-term care system of services that can enable all of us to enjoy this idealized system. But we will need support from younger generations. Thank you.
Thank you very much. Okay, Steve?
Okay, I guess I could just say ditto, but since I've got 10 minutes, I'll take it. So I thought I gave you some very specific details at the end of my other presentation, but I thought I would look a little more 30,000 foot level and really sort of pick up where Fernando left off and talk about the fact that we need a long-term care system of supports that's based on social insurance and not a welfare system. And all of the programs that we showed you were by and large for low-income persons in California. And it was fragmented and it is inadequate. But if you are just above the eligibility levels for those, it's even worse because you don't have the money to buy what you need, and you don't qualify for the services that you need. And then even if you're middle class, how many of you have been asked by family and friends about where do I go to look for assisted living, or what do I do when, right? You know, so we're all the experts in this room, but people don't know, regardless of income, where to go, what to ask for, what's available. And so if you had a universal system that was available to persons of all incomes and that everybody paid into, you'd have a much more coordinated system, both informationally as well as logistically. And we've tried that. So back in the late 1980s, I'm sure many of you remember Congressman Claude Pepper. And he did a fantastic report, and everybody was very excited, and it was presented to Congress with great fanfare. And I still have a bound copy of it, and that's all that remains of it. And the barrier there was financing. Everybody thought that it was a great idea, but he didn't identify where the money was coming from. And I think that's what Deep Sixed the CLASS Act was, that it was a great idea. People thought it would be a good first step towards a universal program, but the way the law was written, the financing didn't quite work out. So one of the barriers that we need to overcome is to think about how we're going to pay for it. And everybody has to pay for it if it's going to be possible. So that means the values that underlie this ideal system are shared risk and shared responsibility. I know, so how many of you have long-term care insurance, private long-term care insurance? Wow, this is definitely an outlier group. So nationally, about 10% of people do. And people often don't buy it if they can afford it because they say, well, I'm never going to use it. So how many of you have homeowners or renters insurance? 100%. So how many of you complain when your house doesn't burn down or your apartment doesn't get burgled? So we should be glad when we don't need long-term care insurance, but it should still become the norm that everybody has it. And if it's a universal system, then everybody is expected to be or is already involved in it. How do we get there? That's the rub. So we mentioned earlier, existing systems provide barriers to changing systems. A number of years ago, there were some initiatives at the state level to coordinate some of the long-term care programs, which are in at least 5 or 6 different departments at the state level. And there was a lot of resistance because aging and social services and rehabilitation and healthcare services and public health were more than happy to increase their portfolio of services, but nobody wanted to share and give up some of their authority to another department. So the existing system actually serves as a barrier, and I'm not quite sure how that can be addressed at the systems level. So perhaps what we need to do is to do more of a grassroots and bottom-up approach. I often like to use the tobacco control movement as an example of how you take an entrenched system with a lot of money and political power that doesn't want to budge, and you basically work at the roots and you start locally little by little, and it turns into a national movement that actually can have some effect. So raising awareness, most people don't know that they'll need long-term care services. Raising the shared risk that we all may need it, and so everybody should be paying into it, just like we do with Social Security or with homeowners insurance. And then shine a light on the way the system is operating. I didn't get a chance to mention the last Q&A, so I'll just throw in a lot of the changes that we're doing aren't being well monitored. So when we went from adult day health care to CBAS, nobody actually knows what happened to the people who didn't make the transition. Nobody really followed them to see, are they getting better services in this program than they were in the last one? And as we're moving into more managed care, other types of services, we can all say this is what we think is going to happen, but I hate to say it as an academic, our plans usually don't exactly unroll the way we think they do, regardless of how well they're planned. And so we need to have shine a bright light on what's happening, pay attention to consumer experiences, so that as the system evolves, as we move towards an ideal, we can make the tweaks and ensure that people don't fall off the train as we're moving forward. Thank you.
Thank you. Laura?
Good morning. I'm Laura Trejo, and I'm the General Manager of the City of Los Angeles Department of Aging, also known as a root shaker, I guess. I'm trained as a gerontologist, and I've had the honor and privilege of serving the residents of Los Angeles for almost 30 years now, believe it or not. Los Angeles is unique, if we can go to the first slide, in that we are the only place in the country where we have two designated, federally designated area agencies on aging. We're very proud of that fact, and we work collaboratively and almost seamlessly at this point. The goal of AAA's is to provide a range of options to allow older adults to choose home and community-based services and living arrangements that suit them best. AAA's make it possible for older adults to remain in their homes and communities as long as possible. I believe that in the previous panel and this panel, I am one of the folks that is speaking to you about how do we operationalize this at the local level and understanding the system of care. So my perception and my recommendations are going to be from the provider level, responsible for over 600,000 older people in the city of Los Angeles. We are both a department managing a very large scope population. You see our goals, you see our core functions. Really, we are advocates as AAA's, we are systems planners, and we're service delivery agencies. Those are the basic nuts and bolts of what area agencies have been designed to do. California is very lucky. It has an extensive network of 33 area agencies on aging, and we also have specialty programs for Native American seniors in the state of California. We really focus on serving those who are the most frail, the most economic in need, and the most socially isolated. We're very proud of the fact that our provider networks are neighborhood-based. I think we are one of the few systems that exist in our state that were specifically designed to meet the needs, the community-based needs of older people as they age in place. So AAA's are an important component of the community-based long-term care services and support for the state of California. Next slide. This is just to give you a picture of my world. Los Angeles County has about 1.7 million older adults over the age of 65. 1 in 4 Californians lives here. The city of Los Angeles has about 40% of those residents. Our population currently reflects the diversity that the state will see in about 20 to 30 years. So Los Angeles is ground zero if you wanted to look at systems development, systems integration, systems redesign, and visioning. What we see when we look at our population is the tremendous diversity, the tremendous need, and we also see the span. Los Angeles has anywhere from highly urbanized areas to highly rural environments. So we really are, I think, a living laboratory for California. Next. Some of the barriers, we were asked to look at barriers and challenges facing California. As you can see, I just listed a few. I just went down a list, and because I kind of gave up, and I thought, that could depress me. California's older adult population is here, it's growing, and it's increasingly diverse. It requires a tailored approach. Part of the frustration I think most of us feel in looking at the system is that we're being asked to plan for 40+ years of the lifespan. That's extremely difficult. When you look at other populations in parallel, children, we talk 1 to 5, we talk 21 to 25, transitional youth, we talk about teens. I mean, it's highly segmented. When we say older adults, we go, everything over the age of 60 belongs to you, figure it out. Well, that's anywhere from 60 to 110 plus. That is a long part of the lifespan, very dynamically changing for the individual and also as how they relate in communities. So we really need to start looking better, I think, if we are planning truthfully for an ideal system. How are we going to appropriately segment and create opportunities so approaches can be tailored that address that 40+ part of the lifespan? The speed of change in our environment is extremely rapid, so it requires that we be not only prepared to address that speed, but also that we have to be very flexible and our responses have to be very quick as well. In the last few years, I can tell you, it feels like we're managing in the whitewater. If you think about rafting, we are constantly being challenged. In the last 5 years, we've seen a tremendous dismantling of the community-based services and supports for California seniors. The fiscal crisis really had a devastating effect on older adults. We were no one's priority, and that was extremely difficult to accept at the local level because we were not only accepting the cuts from the federal level, the state, the local municipalities, the counties, philanthropy, and private donors. So everybody was in the same space, and basically we were just eliminating programs almost on it felt like on a daily basis. I know it wasn't, but it really did feel that way. We really have tremendous needs. Fernando mentioned housing and transportation. Without those two core elements, people literally cannot stay in their homes in the community. If people do not have safe environments to live in and have adequate transportation systems that really have a range of options, they really are not mobile and become homebound and more impaired and socially isolated. So to us, at the local level, looking at transportation as a major focus of our work is a critical priority area. We've also seen in this span of time the near elimination of the Older Californians Act. California boasted leadership in having a parallel to the Older Americans Act, the Older Californians Act, when the recent years it basically has been defunded. Despite reports going back decades warning us of the continuing labor force gaps that we are going to experience, I just saw, I had an email in my phone right now talking about we're not going to have enough orthopedic surgeons for the number of older people who will be experiencing fractures and other kinds of needs. This is now becoming urgent and emergent. We need to address the labor force issues rapidly. We need to come up with different modalities of how to train people, whether in place, in collaboration with the universities. So I'm looking to academia to really help us out in creating some of those opportunities. We also need to look at the fact that, in my perception, the state level policy changes consistently fail to address that the transition happens at the local level. You know, state policy is made to do continuing care initiative, to do Medi-Cal managed care, but the confusion, disorientation, and where the rubber hits the road happens at the client level, happens in my senior centers. And yet, area agencies on aging and the entire aging network was not even considered as part of continuing care plans. We were not even considered a stakeholder. We kind of had to push our way in the door. That shouldn't happen. The state should be thinking in advance that these systems all have to interact together. So as a result, AAAs consistently get left out, and I think that that's one of the problems of the system right now, is that we really don't think about all the moving pieces and say, how will they interact at the local level? One of my major concerns is that for pretty much since I've been in the field of aging here in California, I have not seen funding for aging programs as anyone's priority. It has always been the specialty area or the leftover. So, thank you. I'm going to go to the next slide really quickly, just to show you some of these have already been mentioned, where we're talking about federal sequester has been devastating at the local level. California, as you can see, has been playing tic-tac-toe with all of our services, so we're pretty much left to nothing. But I want to use an example. The Caregiver Resource Centers, I actually don't operate and have no financial interest in one, so I will disclose. I just think that they're a tremendous resource California has allowed to wither. 75% budget reduction to that program, I think, was a criminal behavior. When you look at how decisions are made in families, family caregivers are emerging in the literature as being one of the critical decision points that causes people to go into nursing homes. And that is the very support that we have removed from our system is going to cost us millions of dollars by cutting a few $1,000 from each of the programs statewide. I think it was an incredibly foolish decision that California really needs to look at redressing quickly because families are suffering right now. Next slide, please. This is just to show you the Elder Index. I'm one of the devotees of this work. We really have to redefine how we describe poverty because in Los Angeles, 1 out of every 3 seniors are having difficulty making it. And that's not acceptable in this state. We are an incredibly rich state, and yet we have older people who are literally going hungry. But I do want to take the opportunity today to thank the governor and the legislator for giving us gap funding for sequester for nutrition programs. It means a lot at the local level because that funding has remained flat and we are able to purchase fewer meals every day. Even though the funding is still is there, it's not keeping up with the pace of need. The next slide, please. This is just to show you that at the local level, we're really looking at the transition of acute to chronic care conditions. A recent survey showed that 70% of Los Angeles seniors reporting having at least 2 chronic care problems. That to us is very, very important because it tells you this is going to be the cost driver for healthcare. And if we're not addressing how older people manage their care, it is not going to work. The survey also asked seniors, are you planning? And half of them said they had no plan to deal with their chronic conditions, which I think is very important work that needs to be done in California if we hope to really create an ideal system of care. Alzheimer's disease is a major emergent issue. It's one of the most costly diseases in our nation today. Yet again, we had a very small amount of money in Alzheimer's daycare and it was completely eliminated. This is where we're not really keeping track of what the needs of the state are, even within its own financial house, because it doesn't make any sense to me. The ideal system, we'll go to the next slide, and most of these have been mentioned. Age appropriateness. I don't like hearing that older adults or aging is a social problem or a disease state. It is a state of life, and I think that we need to start putting it in its place and create systems that really embrace that concept. We need to look at consumers and families. That's always a challenge. Which is it? Well, in my world, it has to be both. We talked about cultural competence, community-based, trained gerontology and geriatric specialties. And as you can see, the other one that I think is very important is that systems must support and encourage interagency partnerships, but that also needs an investment. There isn't a budget line in my budget that says go partner with people, but I can tell you it costs me a lot of money to do it well. So if we mean it, then we have to invest and provide some of that resource. We also have to make sure that we're providing outcomes and data-driven decisions. We have the technology in aging now. We can do this. We can do evidence-based programs. Next, please, really quickly. These are some of the components. This is not rocket science. These are very intuitive in terms of just allowing older people to age well in communities. I use the World Health Organization age-friendly cities categories, but these are very intuitive to anybody working with older adults in the community. Next. What is the ideal? As you can see, I have a list of how do we look at creating the ideal system of care among older adults. We currently are a little bit away from that. We need reliable funding at a basis. We can't build a system if half of the time we're trying to build the rocket ship, but the parts are falling off. It just doesn't work that way. We need to make sure in California, if we mean to do this well, that area agencies and aging is one of the major systems of support be included in the decision making of whatever system is being created. We need to make sure that implementation of, we have I think Sandy showed us all the reports. We have lots of reports. We know what needs to get done. We just need to implement something. So that's my recommendation. Please implement something. California, thank you. California needs a strategic and integrated approach. I believe that we have the infrastructure at the California Department of Aging They need the legislative authority from the legislature to do it, so that they can lead the state, because currently they do not have it. I read it yesterday, it's not there. And number two, they need the funding to be able to build the staff support internally, to be able to provide recommendations and support to the other state agencies. That's where your capacity and your expertise lies. My recommendation is like not invent the wheel, let's just finance it so that it can roll. Next slide. How do we get there? As you can tell, I'm a child of the 80s, you know, the $6 million man. We have the population, we have the expertise, we know the needs, we know the challenges, we know what needs to be done. What we need is the will to do it. As a gerontologist, a boomer, and a potential caregiver, I am really putting my hopes in the legislature and our governor to make sure that we're creating the kinds of systems that will be there to support all of us. I really want to commend Senator Liu for her vision in having these public hearings. I appreciate the opportunity to share with you my thoughts. Know that we are prepared to work with you and your colleagues to make sure that we create the level of change in California all of us are preparing to utilize as we age. Thank you.
Thank you.
Thank you. Thank you. Thank you. Love you guys. I paid them to do that. I paid them all to do that. They came with me. Thank you.
Okay, Karen, thank you for joining us.
Thank you. Thank you for having me. Good morning or afternoon. We're almost in afternoon. And it's interesting that I'm following Laura because I have lots to say about our current older adult system. So I want to thank Senator Liu for the opportunity to share my ideas about the ideal long-term care system. How is the volume? Should I move the mic away?
Yeah.
It's fine?
That's better.
Okay, okay. Some say closer, some say it's fine, so look, let me just move it up like a half of an inch.
There you go.
So I have to admit that I don't know whether a truly long-term care system could ever exist. We have a lot of moving parts, not the least of which are the needs of the consumers. However, there are certain essential characteristics that should be present in an ideal system. Can we turn to the next slide, please? Thank you. So we've heard a few of those characteristics today. It's not simply the sheer number of older adults that are sort of creating this sort of complicated system of care, as well as the persons with disabilities. It's the constellation of these persons, and we've talked a little bit about that today. One of the factors that adds a particular level of complexity to the long-term care system and the dilemma and the crisis in the system is the racial and ethnic diversity of older adults in California. Older adults of color are not just one of the moving parts, they are a moving target. As their numbers increase, so too will the number of multiple complex chronic conditions and co-occurring disorders, Alzheimer's disease and other dementias, as well as many complex social needs. So my approach to discussing the ideal long-term care system is to talk about the current gaps in older adult services and programs that seniors are experiencing now. In other words, I'm suggesting that we also focus on prevention as another potential solution to the long-term care crisis in California. Next slide, please. Just 2 months ago, Advocates for African American Elders completed our community survey that identified the service needs of African American seniors in Los Angeles County. We began collecting data in November of 2013. We asked African American seniors about their access, utilization, need, quality, and satisfaction with older adult services in their neighborhoods. We also asked them about their social and economic conditions, health and computer literacy, and knowledge about important healthcare policies and programs such as the Affordable Care Act and the Coordinated Care Initiative. Next slide, please. As you can see from the table of contents, the report is fairly extensive, and there are too many findings to talk about here, but I will highlight a few of them that are relevant for our conversation today. Next slide, please. A total of 550 African American seniors throughout LA County participated in our survey. Findings indicate that African American seniors are healthy, connected, Many are receiving the services that they need and are satisfied with them. However, findings also reveal many service needs and many gaps for African American seniors. This map highlights some of the areas in which we collected our data. Moreover, results reveal low computer literacy and low health literacy across age groups and educational levels. There was also a lack of knowledge of important healthcare initiatives and of available services and programs for seniors in their neighborhoods. The most disadvantaged groups tended to be seniors with low levels of education, those of advanced years, those who lived alone, and those who had poor mental and physical health. Next slide, please. We made a number of recommendations based on the findings about how to increase access to services and programs for African American seniors and how to improve outreach, education, and engagement strategies to increase the level of knowledge about important healthcare policies and available services and programs in their communities. I should note that 81.5% of African American seniors surveyed had never heard of the Coordinated Care Initiative. We also made recommendations about how to improve the quality of services and increase the quantity of services and programs to better meet the needs of African American seniors as they defined them. 27% of African American seniors were not aware of programs for seniors in their neighborhood. Only 42% were currently participating in them. 35% indicated that there were services that they wanted that were missing from their neighborhood and that they needed. That includes in-home supportive services and adult daycare. Next slide, please. We recommended strategies for increasing the health and computer literacy of African American seniors, as findings clearly documented a technology divide among this population across all ages and educational levels. Almost 44% of African American seniors did not know how to use a computer, and 43% did not have access to the internet in their home or any place else. This has huge implications for access to healthcare information and for one's ability to manage their own health conditions. 24% of African American seniors were not happy with the quality of services in their neighborhood, and 91% told us that they believe that more needed to be done to provide quality services to African American seniors. Next slide, please. In our recommendations, we identified particular policies such as the California Homes and Jobs Act, the Supplemental Security Income Restoration Act, and the Positive Aging Act that are needed to improve the economic well-being and living conditions of African American seniors and increase their access to quality mental health services in their communities. Housing, transportation, income were all identified as barriers to access to receiving services in their community. In addition, those who rated their mental health as fair or poor were particularly disadvantaged across a number of domains. Next slide, please. And finally, we stressed the need for advocacy at the federal level to support programs that strengthen the aging workforce and improve quality of care for African American seniors and all other older adults. That includes Titles 5, 7, and 8, which provide funding for geriatrics, health professions, education, and training programs. Since the number of older adults of color in nursing homes is increasing faster than their rate in the population overall, it's important to address the workforce shortage, but to also ensure that those providing the services are culturally competent and prepared and have the skills to do so. This includes competency to address the many physical, mental, cognitive, behavioral, and social needs of older adults. Next slide, please. In 2012, more than 500,000 direct care workers provided an estimated 70 to 80% of the paid hands-on care for older adults and those living with disabilities or other chronic conditions, 376,000 of which were independent providers employed in the in-home supportive services program. Next slide, please. The demand for direct care workers is great and will increase exponentially over the next 15 years. By 2030, 3.5 million additional healthcare professionals and direct care workers will be needed nationwide. Next slide, please. California will also experience a shortage, as the growth projections for the elder care workforce will significantly exceed that of all occupations. All occupations is in blue. Everything else is in red, and that's the elder care workforce. Next slide, please. While the demand for direct care workers steadily increases, the supply will dwindle. Nationally, between 2010 and 2030, women aged 25 and 44, the typical direct care worker, will increase by only 7%, creating a large care gap. Next slide, please. Locally, LA County will be experiencing a demographic shift that will radically decrease the supply of workers. Over the next 2 decades, LA County will gain 867,000 older adults and lose 630,000 younger people of 25 years or less. So it seems as though we will have a workforce problem for a very long time. Next slide, please. The Affordable Care Act extends coverage to millions of previously uninsured Americans, but coverage does not equal care. By next year, the U.S. could have nearly 63,000 fewer doctors than needed, and that number could double by 2025. With the shortage of physicians, it's expected that the most vulnerable patients will have access problems. These patients will most likely be Medicaid population members because Medicaid reimbursement rates are so low. Next slide, please. So let's put these numbers in perspective. 4.41 million older adults in California. In 2011, there were 739 certified geriatricians. That works out to about 6,000 older adults to every 1 geriatrician. We need to train almost 3,000 between now and 2030 just to provide the minimum level of care. Next slide, please. Currently, 80% of care is provided informally by friends and family members. Next slide, please. In 2009, more than 4 million family members provided care to an older adult in California, which equates, as Kate had mentioned, to $47 billion in unpaid contributions. 46% of these family caregivers performed medical and nursing tasks for care recipients with multiple chronic physical and cognitive conditions. Based on the funding made available to support family caregivers in 2013, each caregiver would have received $3.75 for the year. In 2010, the family caregiver ratio was 7.7 to 1. This ratio reflects the number of potential caregivers aged 45 to 64 for every person in the high-risk years of 80 plus. In 2030, that ratio will be 4.1 to 1. In 2050, 2.7 to 1. Until we can better support family caregivers while also providing a system of long-term care, families will continue to struggle to pay for long-term care services and supports, often impoverishing themselves financially and emotionally to get the services that they need. Next slide, please. Clearly, much needs to be done to address the shortfall in the elder care workforce in California and nationwide. In the meantime, current older adult services and programs are not meeting the needs of some consumers. So what does this mean for long-term care? Here is a likely scenario. A low-income senior with multiple and complex chronic conditions is admitted to the hospital. Instead of returning home to their community, they transition into a low-quality nursing home and remains there until his or her death. There are disparities in nursing home care, both in who is more likely to transition into one, as well as the quality of care that they receive. While the number of whites in nursing homes is declining, the rates for African Americans, Latinos, and Asians is increasing as much as 55%. A recent study of 11,500 nursing homes found that those with a high proportion of African American residents had lower costs, but also had lower revenues, tighter operating margins, quality of care deficiencies, and many deficiency citations. While the ACA does not directly address the racial disparities in the long-term care sector or financing the long-term care sector for that matter, the law might help ensure that people have better access to preventative care. It is the direct benefit of prevention, high quality and accessible older adult services that can potentially limit the duration of nursing home stays. Better continuity of care earlier in the life course could reduce costs and complications as seniors age and enter a nursing home, which unfortunately is the most obvious or likely long-term care solution for many low-income seniors who rely on public insurance. Is there an ideal long-term care system of care? Perhaps. However, given the number of challenges, we have quite a way to go before achieving anything close to an ideal. We might even need another baby boom just to meet the future demands for the elder care workforce. So it seems that reducing the number of older adults enrolled in nursing homes, as well as reducing the duration of their stay, will not only lower cost of long-term care, but it might just increase their quality of life from the most vulnerable seniors, as well as that for their families, to allow them to remain in their communities and in their homes. Findings from our community survey suggest that we have a bit more work to do to support our most vulnerable older adults in the community. Why not start improving our long-term care system by improving the access and quality of services for seniors in under-resourced communities to potentially limit the number of preventable and expensive hospitalizations and inadequate support in transitioning from a nursing home back into the community? How do we maintain our most vulnerable seniors in their homes and in their communities as long as we possibly can? The answer to that question is the semblance of an ideal long-term care system, and that is what we should be aiming for. Thank you.
Thank you very much. Dr. Phillips?
Thank you. Thank you, Senator Liu and Madam Berg. And first of all, I have to say I'm not just an annoying voice from Washington, D.C. Now, I may fit that category, and you guys can decide that afterwards, but I really am in my heart and soul a Californian. It's in my DNA, and having spent 20 years, I'm one of the geriatricians that wandered out of practice. So now you got to add one more to your deficit list. And I now work for Leading Age. It's a national organization of nonprofit aging service providers, and I want to acknowledge Joanne Handy, who is the CEO executive of Leading Age California, a very important voice. My role today was to talk about financing, and both Steve and Fernando touched on that very well. So I'm going to hit some of the issues about financing, but also hopefully in the context come out with the ideal. And let's go to the first slide, because we don't really need to know what the challenges are in the financing. We're pretty aware of that. I do want to touch on the fact that managed Medicaid is not the financial solution to addressing. There's lots of other issues, but the costs do not go away. They become more budgetable, so that has attractions to the governor and legislature, but the needs and costs do not go away, nor do they even decrease. 26 states now have managed Medicaid that include some or more elements of long-term services and supports or long-term care. The estimation is that within 2 to 3 years, 36 states will be. So states are moving very rapidly because Medicaid is not the solution for our long-term care financing. And when I talk about protecting middle class, it's not because I want middle class to protect their bank accounts. I mean, that's all nice and wonderful. But the state cannot sustain Medicaid being the support network for all of long-term services and supports, assuming that middle-income individuals or near-poverty individuals who are just above the edge will deplete all their resources into poverty and then assume that Medicaid is a solution. Next page. So right now, Californians are at least a little bit ahead of the curve, and this comes from some SCAN and Associated Press NORC study, that at least you guys are thinking about it, which is good, because when I go sometimes in the flyover states, they say, well, yeah, that's why we have Medicare. And it's like, yeah, no, that's so not going to work. So the fact that Californians are concerned is a good thing. That's a capitalization for advocacy that we have to really utilize, because at the same time, less than a third of seniors, and it's no better in California, have more than 3 months of income to support their long-term care needs. So it's a good thing that Californians are concerned. Moving on, we know that the facts and figures and the costs, not just for formal caregiving, but for the enormous burden of informal caregiving. And Kate, you addressed the fact that age in and of itself is not a predetermined factor for needing long-term supports and services, but it is part of the predictable risk. And just like Steve said, we purchase insurance for our cars and our homes and lots of other things. And in fact, 70% of individuals 65 and older will need some element of long-term services and supports for at least 3 years. So it is a predictable risk, and we need to think about it as a risk that impacts all of us. It's also important to note, and Deborah, I think you would echo this well, Deborah Shari from the Alzheimer's Association, that when we think of disabilities, we either think of physical disabilities that occurred from accident or birth or illness, or that you have a bad thing like a stroke or a heart attack. And in fact, our leading predictive cost for long-term services and supports is our growing population of individuals with dementing illnesses, Alzheimer's and other related dementias. Next slide. I'm going to just skip through these because you don't need to know the numbers because you already know them. Medicare doesn't pay a whole lot for long-term services and supports. And Medicaid, and this is not a good number because believe it or not, CMS doesn't capture what managed Medicaid pays for. This is just fee-for-service. So as managed Medicaid increases, those dollars are going to increase as well. And then the next slide, very quickly, this breaks into a little bit of what nationally Medicaid is paying for in long-term services and supports. And the important thing that we are recognizing, the whole idea of rebalancing, which is the fancy Washington speak for what you guys already know, and that is there is a time and a place and a need for high-quality, good nursing homes. But my preference isn't to make that my first stopping point. Because when I talk about my long-term services and support needs, actually I'm going to move in with Fernando and his wife because I like the idea of the bars and the mariachi bands. But so institutional, and I really like to use the word nursing home care as we need to have high standards of quality, but the dollars are going to shift more and more to non-congregate or institutional settings. So moving on. So the dream, what happened with the dream? So, long-term care insurance was going to make it work. And California really has been a leader in this, and the efforts, for instance, with CalPERS and the long-term care insurance projects that when I was practicing in the 90s really were much of the model of what the rest of the country was looking at. So then what happened? So market began in the 1980s. First of all, people thought that long-term care was uninsurable. We don't do that. That's just, yeah. So the 80s demonstrated that, in fact, there was a market to insure. And then there was a sale of policies, and people moved along. However, and we had that hand raised, it has been a challenge for people to sustain, let alone to access. Move to the next slide. The market collapsed, and the market didn't just collapse just didn't affect our earnings, but insurance companies who make their earnings through investments also had collapses that impacted them directly. So they started to look at areas where they were the least profitable, and long-term care insurance came out of that. And this is off of the California website. 12 companies actively writing business in California, 45 have withdrawn. Most have substantially raised premiums. 100% increase is not unusual, including those on existing policyholders. And therefore, moving on into the next slide, those who want long-term care insurance as it stands now, access is denied. So what can we move? There are some options. There are some ways to look at this. Next slide. We talked a little bit about class, which unfortunately was repealed as part of the Tax Relief Act of last year. But there are ways of looking at perhaps back-end coverage, which means that you do spend down on a certain amount, but you have some catastrophic coverage on the back-end side. Front-end coverage that involves private public payers, tax-deferred savings for long-term care accounts used to be in different ways, and looking at less comprehensive, less compulsory elements to long-term service and supports coverage. Next slide. So Leading Age is part of a group, SCAN, the Bipartisan Policy Center, AERP, Actuarial Services, Millman, and Urban Institute are all working together with some really remarkable thinking. Okay, what do we do and how do we get there? Because there has to be, and so Leading Age published this work called Pathways. There has to be a pathway to make this work. Next page. And so this becomes the spectrum of the pathways. Everything from status quo, which we're all pretty sure is not going to work, to comprehensive insurance where the government pays for everything and I wait for it to happen. And we don't even do that with Social Security or Medicare. So that's likely not going to happen. But there is a whole lot that can happen within that range, and a whole lot that we can, in fact, articulate at a state level. Next slide. So what can states do? And this is taken from work with several other state efforts, and I'll highlight on one. Focusing on education. We've heard that in so many levels. Understanding what do all these things mean? What does Medicare and Medicaid pay for and not pay for? What are realistic costs and burdens for family? What is your risk going forward when you think about purchasing auto insurance or home insurance? Do you understand your risks about long-term care costs? Looking at new private insurance options, finding new ways to incent purchases of those, having portability at the state level between employers or post-employment. And going back to, and I'll end with, because I so agree with you, developing caregiver resource centers, some low dollar investments that have profound yields in the financial costs. Moving to the next slide. So it's not that we model our lives all of Minnesota. I mean, granted, there's only 47 people and they're really cold there. But I guess in their long winters, they came up with some interesting ideas. So they came up with a campaign called Own Your Future. It's publicly available. It's on the web. In my written testimony, I have a link to it that has some very unique and interesting ideas that perhaps state at a legislative level or at an advocacy level we can look at, of ways that at a state level we can have some impact on how we structure the financing of long-term care. So the ideal, the last slide, and I'll focus on, because I agree with all of the ideals that we've talked about in terms of truly having an integrated, cohesive, single entry, meaningful long-term care system. But in terms of how do we pay for it, that value is, covering the costs of long-term care services should not require impoverishment of the individual, nor should it assume that the state then steps in with a Medicaid safety net. In order to have a viable state economy, we have to have a viable solution to funding long-term services and supports. There need to be elements of both public and private. I don't think that either spectrum alone will be the answer. It needs to focus on service-enriched housing for all income people, so that whether you're in affordable housing or you're in middle-income housing, that you have access to services where you live, where you need them, that there's flexibility in benefits in their application. It's really hard stuff, but it won't happen by us saying, gosh, this is really broken. It helps by groups like this, and I'm so proud of all of you, and I'm proud to be a Californian, to be part of this conversation, because this is where the dialogue happens, and this is where, as a state, we can influence our legislators to start to look at what can we do at a state level. And in many ways, California can and should be. We have the demographics, we have the intellect, we have the creativity, and we're not cold all the time like Minnesota. We should be leading the nation in these conversations. So that's a quick overview. There is potential. I'm actually hopelessly optimistic, but I think it's going to be a rough few years, and this is where the work starts. Thank you.
Thank you very much. Thank you very much. Lots to think about. Okay, Gretchen, your turn.
Right.
What, there's a
saved a seat for you.
No, why don't you, no,
No,
speak.
everybody stay.
Stay, just stay. We'll add Gretchen.
Oh, okay.
Gretchen is the Vice President of Policy and Communications for the SCAN Foundation, so thank you very much for joining us.
Thank you so much. It's an honor and a privilege to be here today. Thank you, Senator Lieu, for your leadership and your amazing team of putting this field hearing together. Delighted to be a part of it. I'm going to talk a little bit today about what do we know about how well California is doing on achieving some of these elements of the ideal. So where we had many individuals here on the panel talk about their ideal at the end, talking about the challenges and issues. I'm going to actually start with the ideal in the beginning. And what I'm going to talk about is a scorecard. Scorecards have been done by an organization called the Commonwealth Fund for many years on health systems, looking at how well do states do on providing basic health care coverage for children, et cetera. And we at the SCAN Foundation felt that it was really important to take that same concept and look at how well are states doing on creating a total system of care for older people and people with disabilities. And so with support from the SCAN Foundation and the Commonwealth Fund, we worked with the AARP Public Policy Institute in Washington to look at how well are states doing. So if we can move on to the next slide. First of all, you have to decide what does it mean if you're going to measure what is a system of care. And so getting, in a sense, Senator, to your statement in the very beginning about, what are the values that undergird an ideal system. We put together an amazing group of experts across the country to come up with this rubric that looks at how do you measure an ideal system of care? How do you think about what are those core components? And as you can see on this slide in the light blue boxes, there's ultimately 5 dimensions that we've come up with in measuring how well do states do on providing a system of long-term services and supports. Affordability and access, that idea that services are easy to find and affordable for people who need them. Choice of setting and provider, looking at do people have choice and control over the kinds of services that they need and who actually delivers that care. This is really important because long-term services and supports is an infinitely personal endeavor. This is someone who is helping you bathe, helping you dress, making your meals. So knowing who's going to actually do that really matters. Quality of life and quality of care. This is a dimension that really looks at can we maximize the best outcomes for people in light of what their conditions are and focus on their quality of life, who they want to be and how they want to view their world, and not just focus on just purely the medical conditions, which can really depersonalize people. Support for family caregivers. It was really critical for the group putting these ideas together to call this out separately, that family caregivers, as we've already noted, provide the lion's share of the support to individuals with needs. And so how do we make sure that that backbone of support doesn't get broken? And finally, effective transitions. When I've a social worker by training, been a gerontologist for many years. When I get stuck in corners at cocktail parties with people, as soon as they find out what I've done, and I get the whole 9 yards, right? I hear about the aunt and the grandmother, and what's the thing that everybody talks about? It's those transitions of care. It's those moments of mom had to go to the hospital, and then we tried to get home health, and then it was the nursing home, and then the dementia came, and we got stuck between these two systems. That chasm of how do you help people who need different services and supports effectively transition and move between both of their states of health and well-being and the services that can support them. So what we did is those are all those components, those big five dimensions lead up to a high-performing system. So to get there gets down to what are those individual measures? What are the individual pieces that feed up into this bigger vision of an ideal? And so when we think about that, for this scorecard, we needed measures that had direction. So there was a good, better, best. There were measures that all 50 states had, so boy, that cut out a lot of things. And they had to be actionable in some way by the state. It's not important to measure something if the way in which you measure it doesn't lend you to be able to do something about it. So the end of the story is that there's 26 indicators here that feed up into these dimensions. And so let's see how California did. So next slide. So here is a map of the United States, as you can see, and the darker colored states are the ones who ranked lowest on the scorecard. The lighter colored states are the ones that ranked highest on the scorecard. This is a reflection of the overall. So if you take all 26 indicators and you feed them all up, what's your top number state? And so you can see California. I know we talked a lot that California maybe didn't sound like we were doing too great. Frankly, relative to some of the folks in the rest of the country, we're doing a lot better than some others. But I will tell you, the measurements are imperfect, and we've got a long way to go, because I'll talk to you about some measures that were really in the basement that we need to do some improvement on. So I've circled California as in being in the top quartile. That's that top quarter of states on that overall ranking. So if we move to the next slide, you'll see that where do we fall out on the individual dimensions themselves. So overall, we're number 9 out of all 50 states and the District of Columbia. So the denominator here is 51. When it comes to affordability and access, we were kind of in that second quartile in the middle range. When it looks at choice in setting and provider, we're actually number 2. And I will tell you, that's a testament to the in-home supportive services program primarily. We ranked number 1 on that indicator of showing that people can get the kind of choice and provider when they have the access to that particular program. When we look at, I will say something about affordability and access. Cheryl's just given us a whole 9 yards about the financing issues. And when we look at the cost of home care for people, it's 82% of their average income. That's phenomenal types of cost. When we look at the cost of nursing home care, it's almost 2.5 times the average income of Californians who are 40 and over in this state. So if you think about, do you have the kind of money to pay for private duty nursing home care? Most people, can barely make it a couple of months to 3 months. It's incredibly unaffordable. So I've talked a little bit about choice and setting and provider. When we look at some of the quality measures, most of that data comes from the home health and nursing home industry, because that's where the quality lives. So when we look at some areas where there's some improvement that could be made, the rate of pressure sores among California's nursing home residents are double that of the #1 state. We can do better there. When we look at support for family caregivers, both of these dimensions we're half as good as the top state. We're not number 50, but we could certainly move up. AARP, both in California and nationally, have been really active on championing the roles and the supports for family caregivers, and we have lots of places where we can grow there. And then in that effective transitions category, again, we have a lot of room for growth, as we're number 22 right now. When we have 11% of California nursing home residents have low care needs, which begs to say, do they really need to be in a nursing home or not? That's compared to Maine, which has 1% of their nursing home population has low care needs. So it shows that there's markers where we can do better along the lines. When we look at, where do we need to go with all of these indicators? First of all, we need a lot more information to continue to build out the scorecard, but it starts to set the frame that even with imperfect measures that are out there, there are certainly areas where we can improve. We can move forward with really clear policies and legislative leadership here at the state, and I just cannot thank you, Senator Liu, enough for taking on that charge, and we look forward to bringing on more legislators with you. Thank you.
Thank you very much. Well, good. Okay, we're going to have some time for public comment, but before the public lines up, I have a couple questions to ask. Much work is needed to improve our long-term service and delivery system and to achieve the ideal. And knowing that we can't do everything at once, what would you identify as the major near-term priorities? What should they be? Anybody? Cheryl.
Well, I will say that form follows finance, and I think that there's a lot of other key issues, but we have to find a way to make sustainable finance so that it is accessible to everybody here and their families and all of the other Californians who need it, because otherwise we're creating a collapsible house of cards.
Fernando?
I'd like to throw out a challenge to the group. First of all, this has probably been one of the best collections of excellent presentations from all the groups.
Thank you,
This really has been amazing.
Thank you.
And I've been struggling with how do we get wider public and political support for this emerging crises? And if truth be told, we are using terms that the public does not feel comfortable with. As a board member of AARP, we've been doing focus group sessions, and there's two things that turn off people. One is anything about death and dying, and the other thing is using the term long-term care. It creates in individuals a sense of denial. It can't happen, it shouldn't happen to me. So we struggle with what's a vernacular that can kind of create a buzz. We're struggling with terms like living independently or freedom or choices, but we have a real challenge to how do we broaden the discussion and the public interest by using words, phrases, branding in a way that gets the public's imagination to realize I have a stake in this. The other quick thing, I was intrigued, Gretchen, with one of your findings on the rankings. If you noted the states with the lowest rankings, those are the states where many retirees with resources are moving to.
That's right.
and they're going to places that don't have the long-term care services and support. And I get really angry at the governors of Texas and Arkansas and Oklahoma wanting our wealthy California retirees to go there to spend their retirement funds. But once they need a lot of help, they tell them, go back to the Northwest, go back to California. Anyways, two things I think we have to deal with.
Thank you very much. Yes.
I just have one. I think one of the things that kind of struck me by all of the presentations is that most of us have acknowledged that 80% of the care is provided by family caregivers. So 80% of the bulk of the work should be engaging family caregivers to give us the insights about what they need, when they need it, and how they need it. So consumer involvement, I think, would be a tremendous marker of whether or not we lead towards a successful and ideal system of care, because they are currently the ones that are doing the yeoman's task of caring for the seniors in this community, and they understand them the best. I think it's wonderful to have us here, but they're truly the experts every day when they're doing that work. And when you're in a home caring for somebody, I can tell you as a caregiver, it pushes buttons you didn't even know you had. And so we really need to have that voice embedded into whatever design or policy we are trying to create.
Thank you very much. Karen?
For me, I think it's prevention. My story was prevention. And I think the issue is here, I'm concerned about people who don't have money. I'm not concerned about the middle class who have options, who can retire and play golf. I'm concerned about people who can't afford long-term care insurance. They can't even be denied access or be denied insurance because they can't even afford to apply for it. And so I think the reality for those people, it's still low-quality nursing homes, and it's going to take so long before we can fix those things. The best option for the people that I'm concerned about is to make their lives better here, in their communities, in their homes. What do we need to do that? We're not doing a good job. We clearly are not giving services and providing services to people who need them, one, and when we do provide services to them, they're not happy with them. They're not culturally relevant. People cannot engage with them. They don't see pictures and materials that look like them. The language isn't their language. And I will say one thing about African Americans, we are an ethnic population. You know, in Los Angeles, I'm not from Los Angeles, I'm from the Bay Area, but I moved here from Seattle, and when we talk about immigrants, we primarily refer to Spanish-speaking populations in Los Angeles. There are 10% of the African American population in LA are immigrants, and English is not their first language. And we do not talk about those people. We do not talk about those people. They're getting old. And we can't even serve those who speak English, let alone those who don't speak English. And so in terms of cultural competency, I'm not just talking about being culturally competent for African Americans, which is important, which we do not do. I'm also talking about being culturally competent to Black ethnic groups who have immigrated here and have very specific cultural needs, as do those who have African Americans who have migrated from the South. Very specific cultural needs, and they're very homogeneous. And so I'd like to sort of make that point because I think that point oftentimes gets lost. And the last thing I'd like to say is that we actually talk to African American seniors. A lot of the funding that goes to for some of these programs and services is defined by those who provide the services. They're asked, what do your constituents need? We decided to ask those who are actually receiving the services, what do you want and what do you need? And they told us something very different.
Very interesting. Yeah, very good. So one last question. So what challenges do you believe consumers, providers, and other stakeholders will confront as we go forward in this process? What do you think? Gretchen?
Absolutely. When I think about the clearest challenge that so many of us have brought up today in different ways is that challenge of communication and understanding what the situations are at hand, whether it be a changing system of large magnitude like the Coordinated Care Initiative, or it may be that family caregiver who's brought mom into the emergency room and people inside that health system aren't sure what's happening. They don't have the information that they need. They're not part of an integrated network of data and medical information. They're not sure what the situation is. I mean, we can make that communication lapse, big or small, however we want to think about it. And the continued raising of the visibility that People have needs that at older ages that are oftentimes different than what they were at younger ages, and that the complexity that we see and the constellation of health and function come together in unique ways for people, and the requirement for all of us to raise that visibility that this is a different point in time in life, but that there's a person still there in that middle of that situation that still wants, has goals, needs, preferences, and desires that need to be honored, regardless of whether we're talking big or small, what that situation is at hand.
Thank you. Okay. Suze, I'm going to put you on the spot here, because yesterday we had a pre-conference or conversation out in City of Hope involving consumers, and some of the audience people were at that convocation. Come to the microphone and tell the folks here who didn't attend what we seek to accomplish in this effort.
Is this mic on? Can
Yes.
you hear me again? Okay, so what the senator is talking about is yesterday we had what we called a listening session. We had it out at the City of Hope. We were kindly hosted there. And we invited seniors who were the consumers of services to attend. And we gave them some information about the select committee and what our purpose was, and also asked them some of the similar questions that are being asked today. What are your needs? What are your experiences accessing those needs? What changes would you suggest that would more helpfully fulfill those needs? And a lot of it I've heard resonated in some of the research that was presented today. One of the big takeaways from yesterday, and we will be publishing a summary of that grouping. What we did was then break up into smaller discussion groups. One group discussed specifically coordinated care initiative. They were dual eligibles. And then the other three groups were a mix of both. We had people come who were consumers of services, but we also had a few service providers had come, and so were peppered into the process. One of the big takeaways that was resonated here is just information about what services are available, and then how to access that information. Some of the folks there participating were caregivers, and they talked about the frustration of knowing what was available, how to get there, and then just the lack of availability. For instance, in the case of adult day health care, that there was only one facility within a certain geographic range of her that could meet her needs for her mother's care during the day when she works, which I think we saw the data that a number of these caregivers are fully employed and also trying to do caregiving at the same time. And the idea that there are a level of services that may not be specified in any kind of list of services that are provided that include needs like socialization and overcoming loneliness and the ability to stay active in order to prevent things like depression, dementia, and progression into Alzheimer's. So I think those were two of the big, in addition to the absence of services, the total confusion of the information, and then the actual availability of services within an accessible range were some of the three resonating themes. And then we had some of the other groups talked about transportation, access to transportation to get themselves around, and of course the affordable housing issue also arose. So those findings will be summarized and also available on our website, as will the presentations that you've been hearing today and some additional work that was presented yesterday that adds more detail on the coordinated care initiative.
Thank you very much. Yeah, good. So you can see this is the beginning of a conversation. I mean, many of you have been involved with these topics for a very long time, and as I get grayer, I'm getting more concerned about what's going to happen with me and my husband. So, and it's a continuing conversation to have, because I too, just as a consumer, am befuddled by the just overburdensome of all these programs, and how do you access them, and who gets qualified, and how this how this works together in order for me to maintain a, you know, it's very personal for all of us, right? How do we maintain our well-being in this last coasting down the coast here of life? So this is an opportunity for you to now come and ask questions to all of the experts that you've heard today, or even to ask of us what we can do better for you. We're happy to entertain most things. Please stay. Why don't you guys just stay? Thank you. Relax. Okay, so please identify yourself, so that because you will be recorded, and make your questions brief, and we'll try to answer them the best we can. Good morning. So that everybody can have a opportunity to be heard.
Good morning. My name is Maggie Belton, and I'm with the Personal Assistance Service Council of LA. I wanted to say, if beggars were choosers, they would ride horses. However, I don't have a horse and I can't ride it. I wanted to say I am disappointed in one thing that in several, but you know, me, Senator Lou, you know, disappointment is one of my things. Dr. Wallace had an opportunity to bring to this meeting, or somebody who could put a face on the things he was saying. And that was a real disappointment to me. I am one of those people that all of these statistics that all of you had was talking about. It is Old Home Week for me. I know this one, I know that one, I know that one, I know those over there. I've been in this game a long time. There should have been people who are receivers of the service as a panel here too. It's fine to have it out of City of Hope. But these are, what I'm seeing here is what we call them suits. They deliver the service. I wanted them to hear from others like me. And that's what this should have entailed.
Okay.
And I'm gone.
Maggie, I understand that, but this is the beginning. We're setting the stage for other conversations, and we will certainly appreciate your comments. And we've had a long relationship, and you know that.
Yes.
We will be back.
All right.
Thank you very much.
Okay. And I'm expecting to be included.
Michael Haas, California Senior Legislature. We've been hearing a lot about programs, and the programs flow from needs. But to establish the needs, there should be a prior identification of rights. And that word has not been mentioned until now, although I did mention it to Gretchen. And the question I have is, do seniors have any rights? Are they considered citizens with rights, or are they subjects? What I've found here coming to California is that Californians treat seniors as subjects, as a group to be treated as subject to colonial power, in which those in authority proclaim rules without any legal basis and force seniors to conform. And I've got many examples on a sheet, but I'll give you one. I go to have lunch at a senior multipurpose center. One day, a sign was put up. You can't take out leftover food. Well, we go to a restaurant and we take out leftover food as citizens. But we go to a facility operated for us and suddenly we're subjects and we cannot take the food out. And so I'll give you the other examples on a piece of paper, but I would like to ask if we're treated like subjects when we try to get services, does the California Senior Legislature really feel we are citizens with rights? If they do feel that way, then publish the rights. Put the rights on posters at the facilities where we get our services. If we do not have those rights, we will instead have obligations which have no legal basis at all that force us to conform. And I think that everyone here realizes that if we don't have rights, we're not going to have programs to satisfy our needs.
Thank you very much. Thank you.
My name's Diane Ward, and I'm a geriatric case manager, and I work for an agency that is funded through AAA, and I really appreciated what you had to say. On all of those points of service, I didn't see one little square to talk about integrated case management, which is what I do. We really are the foundation for touching seniors and finding out what their individual needs are. And we always look to seniors to the right to self-determination, sir. So they do have rights. That's a very important part of our care. We work with the senior to enable them to stay in their homes as long as possible, as safely as possible. Our programs have been cut back substantially. I've never worked so hard in my whole life for so little money. And this is my second career in life. I didn't start it till I was, start the education process till I was 50. And now I am a senior. And I wanted to say one more thing. We have a program called the Family Caregiver Support Program. Okay? I facilitate caregiver groups. I hear firsthand what they need. And what they need is not funded. That is the big thing. They need respite services. They need transportation services that facilitate instead of cause them to have to stand outside and wait for access services. I also serve Antelope Valley. And how can a senior sit outside in that kind of heat waiting for access services? So there are services there. My job is to create a care plan that integrates these services. I often see competition between agencies. So there's a lot of things. We need to cooperate, okay? There needs to be, you know, the idea that there's enough to go around, and although there's not, but because this program's funded, this one isn't, whatever it happens to be. But there are services there. Communication is very important. Computers cause problems because it makes everything go too fast and too complicated. There's just a huge gap between what is available and how to understand it. Huge.
Thank you. Thank you.
Thank you, Senator Carol Liu, for conducting this event and the job well done with the committee. If you don't mind, I'm going to read my message to make this quick and limit the time. I am Helen Wong, and I'm the president of the Arthritis and Fitness class for the past 7 years since the program began, and is now under the Los Angeles Unified School District Division of Adult and Career Education, East Los Angeles Service Area. Class offered in collaboration with the City of Los Angeles Council member Gil Cedillo. Class held at Glassell Park Senior Center every Monday and Wednesday. Senior folks need to exercise to strengthen their body and relieve their aches and pains. It's very important to continue the senior program for these folks to attend, not only to exercise, but to socialize and maintain their physical health. Many are grandparents who babysits their grandchildren, but they need to be healthy and capable to care for their family. Today, senior folks have longer life expectancy. Consider the importance of their life today and their future. Our program is in jeopardy. We need funding for our older adult program. Please save our older adult education. Thank you.
Thank you very much.
Hi, I'm Karen Rosenthal. I'm from the city of Claremont. I am a member of the Committee on Aging, which has provided support for senior program staff. It has devised programs. We have a number of committees that are helping to fulfill seniors' needs in Claremont. But I also come from the other side. I was a council member, planning commission member, and mayor of Claremont. And one of the little niggling challenges that we see in the background is with the emphasis on aging in place, we also have deteriorating neighborhoods, economic deterioration because seniors do not eat out as much, they don't buy new cars, they don't go to the gift shops. I see all of your heads going, oh yeah. And for a while, Claremont had a special building fund issued through one of the departments to provide money, which obviously many seniors don't have, to repair the roof, paint the front door, do a little gardening. And so you really need to think about the economic problems that face especially smaller communities or neighborhoods with the aging in place and our aging senior population. So it isn't all just their physical needs and emotional and socialization needs, it's what the community needs as well. Thank you very much.
Thank you very much.
Hello, Senator Liu, and thank you for convening this important meeting. My name is Dr. Deborah Cherry. I'm from the Alzheimer's Association, California Southland chapter, and we recognize your leadership. I'm here to talk very briefly about the epidemic that is Alzheimer's disease. We know from data that the state has about 600,000 people afflicted by the disease, and that within 20 years, because of the surge of the boomers, that number will double. I know it personally because I walk in this room, and for the first time, not the first time I should say, but because I walk in a room like this and 2 people came and talked to me about parents with the disease. Last weekend, I had a dinner party I went to, and it was the mother of one of my kids' parents who had the disease. It's happening increasingly, and maybe I see it more than others because I'm in this position, but I think that there is an epidemic and we just don't recognize it. In 2008, under the leadership of the state's Health and Human Services Agency and the state's Alzheimer's Disease and Related Disorders Committee, we created a state plan for Alzheimer's disease. I brought a copy, and we can certainly get you a copy. The state plan has not been brought to life, partly because the economy fell the way it has for the last several years. But we have some opportunities now. We have some opportunities to breathe life into it and to make some home and community-based services work for our families. We have the Coordinated Care Initiative, and with the leadership of our State Department of Aging, we acquired federal funds to train care managers in all of the managed care organizations to do a better job of recognizing people with dementia and providing them with triaging to figure out which services they need. And we need to do a great deal more because that grant's only going to get us about that far, and there are that many managed care organizations to go work for. We have in our state plan an update of a California guideline for Alzheimer's disease management. I look at the panel and I recognize people who created that guideline for Alzheimer's disease management. Right now, if a person gets a diagnosis of Alzheimer's disease, and only 50% do, they at best get told, oh, you might want to use a nursing home. But they don't get given to somebody who can do what a diabetes health educator can do, give them some clues about what's the next step. So we need these guidelines updated or they become defunct. They're now 6 years old. They should have been updated last year. It's not expensive to do, and it's in our state plan. And finally, let me mention that we have, for the last several years, collected data through the Department of Public Health at the state level, BRFSS data, on both caregiving and on cognitive impairment. And this year, there's a challenge getting the funding to continue collecting that data. Data makes things happen. And we need to have that BRFS, those modules in the BRFSS.
Okay.
Thank
you very much. Thank you.
My name is John Gonzalez. I'm a concerned citizen or a senior. I have a sister who's 73 years old. She's caring for my mother, who will be 98 years old in September, and my little brother, who's bedridden, who has Alzheimer and also diabetes. She lives in East LA, Boyle Heights. She's isolated. She needs to be able to have people around her that she could be able to share this type of, get support. A lot was discussed here about how to be able to get this message. It's wonderful that we all got this message here, but people in low-income communities, it's very difficult to get all this, and you have to simplify it. One of the ways I feel that I know that this message and also prevention is very important. And older adult education through LA Unified School District or throughout the state is one way that this message can be reached locally, and that would be help to be able to save this program, who is about to be discontinued or disfunded in approximately 1 year. Thank you so much.
Hello, and thank you very much for having this meeting here at this time. My name is Anne Marie Kopakin. I am the director of the vocational nursing program at Santa Barbara City College, and I've just spent the last semester on a sabbatical to develop a brand new direct memory caregiver program for Santa Barbara community. Unless you're fortunate enough to be related to the panel, the people who are caring for the person with dementia have virtually very little to no education. And so we are looking at bridging that. I want to basically speak to two things. Number one, for those caregivers, we are looking in Santa Barbara, those caregivers get paid $15 an hour. They can't afford to live on that type of wage. So we're looking in Santa Barbara of having a community partnership, working with the city and the county to perhaps help to pay for childcare for those people, to help to pay for housing, giving them some housing bonuses, because you have to look at that caregiver and try to keep them in the community. Number two, one of the things that I was just astounded at is that we have an early childhood education, ECE program, because they quickly figured out several decades ago that not just anyone off the street can take care of a child. Well, we need another ECE program, which is an elder care education program, because right now they're just pulling people off the streets. So, all right. Number two, the other thing I wanted to talk about is, again, as a person who teaches in nursing homes, our current regulations encourage a task-focused care. It encourages my nurses to become box checkers rather than heart carers. What we need is to have our nurses spending less time with their computer mouse, touching their mouse, than touching their patients. And so when you develop something, really watch those regulations. I feel that my program is a social-based rather than a medical-based program. We need to get nursing homes away from medical-based and get back to the heart of nursing. So thank you very much.
Thank you very much.
Senator Liu and committee, thank you very much. My name is Marcia Gould. I am a member of the California Senior Legislature, representing seniors in the city of Los Angeles. Also, as part of this, I am a member of the Legislative Committee, and our job is to visit legislators during the year to explain the different proposals that we've written to benefit seniors. Along with this job that I have, and I visit 12 senators and assembly people several times a year. Unfortunately, you're not on my list. I wish you were. So because of this, I decided to take a hold of the book that's published by the legislature, which gives information on all the assembly members and all the legislators, their name, their background, their information, and the very last thing says their interests. Out of my 12 legislators, one hinted that senior issues is part of what they are in California to do. So I'm asking right here that you do something talking to these legislators. We've already decided that that's the bottom line here. We need to have legislators who want to support seniors. If in this book there are just a couple that talk about seniors, we're not doing our job. So that's what I would like you to do. Thank you.
Thank you.
Good afternoon. Thank you so much for holding this today, and I'm really personally excited about the new Aging and Long-Term Care Committee. My name is Molly Davies. I work for Wise and Healthy Aging, and I administer the Long-Term Care Ombudsman Program and Elder Abuse Prevention Programs throughout the City and County of Los Angeles on behalf of our local area agencies on aging. So a long-term care ombudsmen are advocates for residents in nursing homes and assisted living facilities, and we investigate complaints made by or on behalf of them and their caregivers, because caregiving doesn't stop the moment you move a loved one into a facility. It transforms into advocacy. So just want to make sure that that continues to be part of the discussion. Just want to ensure that residents in long-term care remain as part of the discussion. Folks who are in facilities for short term, but then there are also folks that are there for very long term. Want to also just hope that you will tap into organizations like the Long-Term Care Ombudsman Program and the California Long-Term Care Ombudsman Association in having these discussions. And also, if you're interested in meeting with constituents in long-term care, I could certainly facilitate that for you so that their personal voices could be heard by the committee. Thank you.
Thank you very much.
Hi, I'm Karen Jones, and I'm with the San Luis Obispo County Long-Term Care Ombudsman Program. And I do want to thank you also for having this today. What an amazing group of speakers and presenters. It was really great to hear so many people interested in something I've spent 15 years really being very interested in and watching. Doesn't always seem like a lot of folks care as much about the long-term care system. So I'm looking forward to seeing changes. The reason I'm here today is to make sure that we, again, as Molly said, really include the Ombudsman Program, not just, though, in the care facilities, although that's where I specialize and I don't want to move into any other location, but when we're talking about long-term care system and delivery for people in the community, in their own homes or wherever their home may be that's not in a licensed facility, to make sure that they also have an ombudsman, somebody who can speak for them on their behalf, somebody who can meet with them and be an unengaged, not part of their current family situation or caregiving situation, to speak independently for them so that they have a voice and that they have someone who can think for them, with them, and not be overly involved. For instance, I have a case that actually blew up just now while we were talking, so I had to leave the room for a few minutes, where a very nice gentleman in a nursing home, he's got too much family, frankly, and they're fighting over him. And they factioned off, and it's a giant battle over who's going to be in charge of him. And his family cannot be his advocate because they're so involved in the fight between themselves. He has to have an ombudsman. In fact, I've got 2 ombudsmen sitting there with him right now. So I just want to point out how incredibly important the advocacy piece is. No matter what you do with the system, people need to have an advocate. Thank you very much.
Thank you.
Is it obvious? Good afternoon, Madam Chair. Before I begin, I just wanted to share with you, I have been a clinician in the San Gabriel Valley for the last 40 years. I've been in public service and have seen this evolution of care back in the mid-'70s. I know that I've worked with several of you on this panel, several in this audience, I truly know that I am now a senior citizen. And the day when we entered this field, we always would look at everyone and wonder, you know, that will be me someday. And we tried to create programs at that time that we would want to participate in. And there's a huge pride in that, and I want to applaud all of you guys because it just lifted my heart, regenerated my spirit. And so what I just want to share with you today, my name is Marian Last, and I'm the Vice Chair of the California Commission on Aging. And the Commission has statutory responsibility to serve as an advocate for the older Californians, as well as serving as an advisor to the governor to the governor and the legislature. There are 18 members that compose this commission, representing from Northern California as far north as Chico, as far south as San Diego. There are 2 of our commissioners today, and I see a past commissioner on that panel with us as well, and it's another blessing. We are appointed by the governor, State Rules Committee, and the Assembly Speaker. As a commission, and I'll mimic what Sandy had said earlier, we see a robust statewide system that supports older adults and their respective caregivers. We need to give them access to the abundance of resources for that independent kind of living, help them age in an environment of their choice. In doing so, we will embrace diversity and respect that aging process. The background paper provided by the committee in preparation for today's meeting presents eye-opening challenges that similarly existed in the 70s. And we did prevail then, and we certainly have to prevail now. Our commission enthusiastically looks forward to working with you in promoting a comprehensive and well-coordinated system of long-term services and supports for the future. Thank you all.
Thank you very much.
Hi, my name is Donna Benton, and I'm representing Pacific Clinics and the University of Southern California Family Caregiver Support Center. I want to give a shout out. I want to say my heart was lifted so much by hearing a recognition for family caregivers that I haven't heard in a long time. But I also want to point out that it is going to be vitally important that we do address the mental health issues that occur with our family members and with our older adults, and that we do integrate the Department of Mental Health and make sure that there is support, because there are programs there for both prevention and for those that have suffered with mental health issues for a long time. But I think one of the things is, Laura, you pointed out something that I think so many of us forget. It's about cohorts. And within our mental health system, we've segmented all of the age groups until we get to older adults. And then, like you said, it's free for all after 60. And I think that it is very important that that piece maybe gets looked at, about looking at the cohorts and how that, you know, it's not the same for the Mick Jagger generation versus the other generations, and they really are going to be different. So thank you. I know we have more people, but thank you so much.
Thank you very much. Thank you, folks. We had a 1 o'clock deadline to be out of the room, but we have about 3 more speakers, and so let's wind it up as quickly as we can so everybody is happy.
Thank you. My name is Aida Villalobos, and I'm the president for the Los Angeles County Commission for Older Adults. We service about 1.7 million seniors. My pitch today is that we need more education. We need more to let the people know the availability of those programs. And I mean this to be done in any language possible that you could. We come from different cultures and different nations and different countries. I come from Puerto Rico. In Puerto Rico, the older adult will be taken care by the family. There were no nursing homes, no convalescent homes. My grandmother was 110 years old, and we were still taking care of her. So I know that you guys are trying your best, but we've got to go more to the public with all the information. And I tell you, I'm here to tell you, it's a shock when you come in and face the need for that long-term care. My sister, who was in assisted living and then fell and had to go to the hospital sent her to a convalescent home. The convalescent home went back to the hospital. We were not prepared for it. It was a complete shock. And she was not prepared for it either, and she only lasted something like 3 months in that convalescent hospital. So, like I said, in every language, in every way you could, educate the public. Thank you.
Thank you.
Hello, my name is Ida Potash. I'm a citizen. I'm also a member of the Griffith Park Adult Community Center and CARA, the California Alliance for Retired Americans. I want to, first of all, thank you very much. This is long time needed, and hopefully it'll just be the beginning of where we go from here. But I want to address the second gentleman who spoke in terms of, are there rights for seniors? Yes, there are, and they come under the Older Americans Act, which was a federal program that, among other things, guarantees nutrition, socialization, access to housing, to up-to-date medical and mental health care, among other things. It is up for reauthorization right now, and I would encourage everybody to contact your federal legislatures to vote yes to reauthorize this. Otherwise, we are going to lose those rights. Thank you again. Bye.
Thank you.
Thank you, Senator Liu. Thank you, all the speakers. You guys do such a great job. The information that you shared was so right on. My name is Linda Chavez, and I work for Community Senior Services, which is a very small nonprofit in the Pomona Valley. Recently, there was a budget proposed that would wipe out Senior Corps. Senior Corps needs to be part of the discussion. We have so many wonderful people that are over 55 that are volunteering in their communities, and they can fill some of those gaps in service, and they can provide some of that customization that someone needs for services in their home. So I would just encourage you to make sure that Senior Corps is included. Thank you.
Thank you very much.
Thank you, Senator Liu and distinguished panel. My name is Jacqueline Sigobin. I'm the Director of Affordable Housing for B Group. We're doing it. We're doing it and living it right now, today, this very minute. We have 5 communities here in Glendale serving the extremely low-income senior citizens. We're providing services. I want them to die at home. I don't want them to go to the nursing home, but I need help. I need partnerships. We need the managed care organizations to partner with us. Our caregivers, yes, 90% of them are family members with no education on how to treat a family member that has dementia or Alzheimer's. I have amazing team members. We get paid. We don't make the big bucks. We do it because we love it. We do it because, quite frankly, they could be our mother or brother or father. That's why we do it. But my staff are abused on a daily basis. I have to make house rules about verbal and physical abuse that my staff have to undergo by family members who expect us, independent living, expect us to take care of the family members. It's just expected. They're living in our housing, we need to do it. The federal government, the Department of Housing and Urban Development, they stopped the development. Senator Liu, you have to fight for the development. It has to continue. We have over 200 people on our waiting list. The expected time to wait for housing is 5 years. It's the most difficult conversation I have on a daily basis. Yes, you need housing. Sorry, you have to go on a waiting list. Most of them die before they get there. So we need education, we need partnerships, and we need the federal government to really think about reinstituting the development of continued affordable housing for long-term, for senior citizens. And just to answer your question, I have 140 nations in all of my communities. We have a limited English efficiency plan. We can speak the different dialects and the different languages, and if we can't, we do Pictionary dictionary, so we can figure it out. and we can communicate with our seniors. So please support the government in providing housing for seniors. It's not just the rich folks and the middle income folks that need taken care of. We all need it. So please, let's try to encourage the senator to continue to support it.
Thank you. Thank you. Okay, so briefly, a camera was found. So it's at the registration table if you've misplaced or lost your camera. And I really want to thank all of you today for being here. You've stuck through with us. You've given all of us much food for thought. And I want to thank my Capitol staff and my district staff and my friend Patty Berg, who's been on this topic for a very long time, for putting this event together. And I want to thank our panel and panelists who did an outstanding job today, helping us all trying to gather all this information together, and for the Glendale Public Library for hosting us. So this information is going to be presented to the committee today, that we've heard today, will be presented in a joint hearing in August at this select committee and the Assembly Committee on Aging and Long-Term Care. It's going to be heard in August in Sacramento on August 12th from 2 to 4 p.m. at the state capitol. And you can always call my Capitol office here in Glendale, my Capitol office in Sacramento, my district office here in Glendale for more information. And I really want to thank all of you again for joining us, being patient with us. We've heard a lot of good information that we're going to try to move this ship along. So thank you very, very much today.
Esta es del Senado Estatal de California.